preparatory classes. So with this introduction, I will request Dr. Kalyan Sarkar, our president, to welcome all of you, and then the session will be handed over to our moderator and the chairperson, Dr. Shivaji Basu and Harpreet Singh. Dr. Kalyan Sarkar.
Good morning, everyone. I will only say good morning because I want the proceedings to start on time. There are 4 cases and let there be plenty of scope for discussion. And may I invite Dr. Shivaji Basu, chairperson, and Dr. Harpreet Singh, moderator, to take on the proceedings of the morning.
Thank you, Kalyan. Yesterday's program was fascinating. I mean, when our boys said that the treatment of the renal and ureteric stone involves about surgical treatment. Actually, the basic science, what we discussed yesterday, was extremely helpful. The metabolic evaluation, the pregnancy, the other complications, and was a very good video by the renal access and out-of-the-box presentation by Professor Supriya Basu on extended pyelonephrectomy. All were very good. So we will have to conceptualize those, whatever we learned yesterday, to today's case discussion. I'm sure a lot of things will come up while we're discussing 4 interesting cases. Harpreet, over to you.
Thank you, Shivaji sir, for this encouraging words. I fully agree with you. We had made a beginning and it was a great beginning, I will say. We had a good program yesterday. I'm sure this momentum will continue. As you mentioned, that today is the culmination of that theoretical knowledge which we gained. So without wasting any time, I will invite the first presentation of today from Dr. Nitesh. And the student who is taking the cases today, Manoj, are you there? I see Manoj there. Yeah, Manoj is there.
Take two
Manoj and Dipankar. Manoj and Dipankar.
Yes, sir.
Both of them take the first case. And Nitesh, are you ready with your presentation?
Yes, sir.
Okay, great. So I'll request everyone to mute your speaker. Who are not speaking today, please mute your speaker. And so that we continue flawlessly. Thank you very much.
May I make a little point here, actually, for administration, Ranjan? You know, if you send out a circular that anyone who takes part in this program should actually declare his name on the, you know, they are not visible, that is accepted, but they should declare who they are or their identity on the blurb, actually, that at least the name, the full name, instead of these funny names we see on the okay, so that's all.
I agree with you, President sir. Absolutely.
And also be well visible with the lighting, yes. Right. Lighting,
now, Dr. Harpreet, you please request all the students whenever they are being called to introduce themselves before they start their presentation. Okay. What is their name and from which institute they are joining?
And the Zoom should be modified to declare their, you know, their professional identity. Okay.
Right. So before Nitesh you begin, I'll ask Manoj to introduce himself, and after that Dipankar to introduce. Then we'll begin. Manoj, please introduce yourself.
Hello. Yes, sir. Yes, sir. I'm Dr. Manoj Kumar.
Just a minute, Manoj. Just a minute. Nitesh, can you stop sharing so that we can see, everybody can see Manoj?
Yes.
Just stop sharing, Nitesh.
Hello.
Yeah, just a minute. Yeah. Yes, you can introduce yourself.
Yes, sir. I'm Dr. Manoj Kumar from IGMS Patna. Hello.
Yeah, Manoj, go ahead. Manoj, there's too much glare. Can you adjust your light pattern a bit?
Yeah. Everybody should go align yourself to the proper lighting. Otherwise, half seen is a more problem.
Yes.
Rather than not seen. That's a part of the training, Manoj.
Absolutely. Absolutely. Manoj, for light adjust करो हाँ अब तो better दिख रहे थे एक खाली glare आ रहा था हम लोग कुछ देख नहीं पा रहे थे. Right. Introduce yourself, Manoj.
Yes, sir. I'm Dr. Manoj Kumar Singh from IGMS Patna. I'm third year MCA president.
Okay. Dipankar.
Yes, sir. Good morning, sir. I am Dr. Dipankar Bera from NRS Medical College and Hospital, Kolkata.
Which year?
Third year, sir. Third year.
Okay. Okay. Sir, can we begin now? Sir, Shivaji, should we start?
Yes, sir. You can start now.
Okay.
The next session also you ask them to introduce themselves.
Absolutely. Absolutely. They should introduce them only. Okay. Nitesh, a word from, you also introduce yourself once again to the audience.
Good morning, everyone. Seniors, fellow colleagues and juniors. I'm Dr. Nitesh. I'm working here as a consultant urologist in Ford Hospital and have my own private practice in Patna.
Yeah. Start, Nitesh.
Shall I start, sir?
Yeah, Nitesh. We are absolutely on time. Finish on time.
Okay. So starting with the first case, a 67-year-old lady, housewife by occupation, presents with chief complaints of left groin pain since 1 year. The patient was asymptomatic 1 year before. Then she developed right flank pain, which was mild to moderate in intensity, intermittent, radiate sometimes to back, and relieves on self-medication. She had 3 episodes of burning micturations, mild urgency and frequency in last 1 year, which was treated locally by antibiotics. There was no fever, pyuria, voiding difficulty, lithuria, decreased appetite, nausea, and vomiting. The question goes, do you want any other history in this present illness, or you are satisfied with this?
Is there history of hematuria?
No, there was no history of hematuria.
Excuse me, sir. In the chief complaints, you said the pain was in the left flank, but in the present illness, you are saying it is in the right flank. Which side is the pain?
No, it is left. Sorry, it's mistakenly written. It's left. Consider it as a left.
Okay.
It was a typing mistake. So moving next.
Burning micturation episodes were associated with fever, high-grade fever or not?
No, there were no fevers. There was only burning micturation.
Okay, sir.
Going to her past history, there was no any history of urolithiasis. She is diabetic for 5 years, hypertensive for 5 years. She is a patient of coronary artery disease. She had an angiography and stenting done 3 years back, and she is on dual antiplatelets. There is no history of COPD, allergy, or blood transfusion. She had her uterus removed around 15 years back. She is married with 2 children, both for normal vaginal delivery. She takes a normal mixed Indian diet, no tobacco, no alcohol. Now next is examination. Examination is almost normal. I will not waste time on this. Abdomen is also normal. So what next?
Then I would like to say about the diagnosis in this patient. 67-year female with left flank pain, with history of burning micturation and frequency for last 1 year, with diabetes and hypertension on medication, with history of stenting, mainly the cardiac stenting. So in this case, my first diagnosis will be left renal stone.
Okay.
Then,
any other differential diagnosis you want to put in?
Yes, it can be left UPJO. Then
okay.
Maybe cystic disease of kidney.
Any other things anyone wants to put in?
Sir, this can be...
Because there's also storage loss with flank pain. So my fourth DD will be UPD also.
Okay.
So this can be a case of recurrent pyelonephritis, sir. She is presenting with left flank pain, and also there are episodes of burning micturition 3 times in a year. So can it be a case of recurrent pyelonephritis?
Anything else? In this elderly, if you revisit your OPD memories, many patients will come, diabetic patients will come with cystitis and UTI-related symptoms. And ultimately, you find that she is having simple cystitis. And the pain is often unrelated with back pain, because this prolapse or some back pain, and they will relate it to kidneys. So this also has to be kept in differential diagnosis. Okay. So how will you investigate?
Sir, I would like to do some basic laboratory investigations, and along with the urinalysis. Among the laboratory investigation, we would like to do the complete blood count, along with the electrolytes and the renal function test, sir. And also, sir, urine for routine examination and culture and sensitivity.
Here is a general investigation. If you want anything else.
One thing I want to know, in the drug history, since there is history of cardiac stenting, either history of blood thinner or any
yes, she is on dual antiplatelets.
Okay.
Aspirin and clopidogrel, both. Okay. Here is a urine analysis. pH is slightly acidic. There are 5 to 6 pus cells. Albumin is present in trace, and urine culture shows E. coli in a significant colony count.
Yes, sir.
What's next? Anything more you want in investigation profile?
Yes, sir. Now we'll go for some radiological investigations, imaging, sir.
Okay. What the first
we'll go for
thing you
the
want?
ultrasonography. Ultrasonography, sir, as it is a extension of the clinical examination and readily available. So we'll go for USG, kidney, ureter, and bladder, along with the post-word residual urine.
Okay. This is the ultrasound, left kidney, and this is the right kidney. So what are the things you want to know from ultrasound in this patient?
Sir,
size of the kidney, any hydronephrosis, any acoustic stat, any mass lesion in kidney, and the parenchymal thickness.
Okay.
Any perinephric collection.
Okay.
These are all I want to know. So in this case, on the left kidney, there is a large posterior acoustic shadow.
Okay.
Likely of stone with moderate to severe hydronephrosis.
there is a gross hydronephrosis, sir, along with thinning. Yeah. You can see gross hydronephrosis, sir.
Okay.
And the right side was normal. There was no hydronephrosis or stone.
A few more things you have to see is you have to identify the cortex. You have to identify the medulla. That the renal echogenicity, if you compare with the spleen, is slightly almost in the normal range. It's difficult for us to identify these things, but by the practice, you will learn how to identify the renal echogenicity, whether it is increased or not, to differentiate between cortex and medulla. If you see this right kidney, you can identify the normal cortex, and you can see the corticomedullary difference, this differentiation. You can see also the normal parenchymal thickness. The other things you want to know from USG is, are there any other abdominal pathology or not? Also, this bladder. What do you want to see in bladder if you are seeing in a USG?
So the thickening of the bladder wall and post-word residual urine.
Yeah.
And if there is an echogenic debris seen within the bladder.
Yeah. So thickening of the bladder vessel wall is also important. What are the conditions you can get a thickening?
if there is blood and obstruction.
Okay. In this case, you are more concerned about?
Cystitis, sir?
Yes, cystitis. So these are the two things. And stones also, if anything else is present, mass also, you can see.
Yes, sir.
Okay. Can you see the ureteric orifices and patency with USG?
Yes, if the ureters are dilated, they can be seen in ultrasound, and the jet of urine also can be seen in ultrasound.
How do you check whether the urine from ureter is coming on USG or not?
The urine will be seen in the bladder in peristalsis. Means in pulses there will be jet of urine in the bladder. By that we can see.
Getting a jet is difficult. When you turn the color Doppler, you can actually see a very nice jet of urine.
Okay.
Okay. What is the next investigation you want? This was the ultrasound report. There is a left staghorn calculus around 3.5 into 2.7 centimeter. The right kidney is normal in size and ecotexture. Right and left ureters were normal. Bladder is normal.
Yes, sir.
We'll do one CT urography.
So CCT KUB, sir, along with urography.
You want plain CT KUB, urography or IVP? Why not IVP? Why CT?
Sorry interrupting. Why not X-ray KUB? First, Nitesh, why not X-ray KUB first?
So X-ray KUB is mandatory, sir. If you go for this IVP, it will be covered in that. So
but
coming to that point, sir.
Yeah, first X-ray KUB I think is the first thing which we ask with the
Yes.
ultrasound.
Yes, it is.
So CT will give us the more anatomical details, sir, regarding the skin to stone distance and also the thickening of the skin.
Okay, first let's discuss the X-ray KUB as said. So this is your X-ray KUB. You tell the findings.
So there is a radio opaque shadow seen in the left renal region and with a staghorn configuration, possibly a staghorn calculus in the left kidney.
Okay. A basic question, it's been dealt in past also. What are the stones which are radio opaque? It's radiolucent, sorry.
Uric acid stone and xanthine stone and
Okay.
uric acid, xanthine, and Indian avis.
Anything else? One more drug stone?
Time train, sir?
Yeah, good. So you want CT or IVP?
Sir,
mainly in this case, there is a large left staghorn stone with gross hydronephrosis. So, and thin parenchyma. So, in this case, if I go for a simple plain IVP, then in that case, left kidney may not be excreting, and there may not be proper assessment of the function of the kidney. So, in that case, we have to go for any functional study. So for that only, I want to go for CT urography. And moreover, there are many, if you go for CT urography, we can know the house feel, we can know the anatomy better, we can assess any retrorenal colon because the stone is on the left side. So these all we can assess in CT.
See, CT has many different advantages, as you said. Other many three-dimensional configurations can be known. Okay, but here for the discussion purpose, we have gone through IPP also. And regarding function, CT, if you see a contrast in CT, even if the kidney is slightly secreting or excreting, the contrast will be seen. In IPP, it said that if it is excreting, GFR is almost normal, it is salvageable. So we have done an IVP for this patient. This is the IVP at 5 minutes. Can anyone read it?
Yes, sir. On the right side, it is normal excreting kidney without any stone, and on the left side, since there is no plain film, no, we have seen in the plain film there is a left heaven stone, and the left kidney is also excreting. This is 5 minutes film.
So it's promptly excreting. Can you see the ureters in this film in the left and right kidney?
On the right side, we can see the ureter till upper SI joint, but on the left side, the ureter is not traceable.
Okay. Can you see the extensions of the stone? They are in which calyces?
In the lower calyx and in the middle calyx, sir.
Not in the upper calyx.
Okay.
It's a film. So on that basis only, I'm saying that this kidney is excreting.
Okay. So the function is good. It's excreting almost readily at 5 minutes. You can see the later on images at 15 minutes. Now can you see the ureter? Left one? Yeah. So it's going. Bladder is also filling at 45 minutes. This was the post-void. What is the importance of this post-void image?
So we can see if the contrast is excreted or not, and also in the post-void image we can see the state of the bladder. If there is any bladder outlet obstruction, there will be retention of the contrast in the bladder.
Okay, so two things you can see in post-void image. One is the residual urine, and the second, if the bladder is full, the drainage of contrast from the kidneys is slightly slower. So you do a post-void, you wait for around a minute or two, and then you go for this X-ray. So if anything is there in the kidney, you can see the right one has completely drained. It was there itself at 45 minutes when the bladder was full, but after voiding, it has drained. The left is not draining, probably due to some obstruction caused by the stone. So I am missing the prone film. Do you need a prone film?
Yes, sir. The prone film will help us in planning the surgical management, because we usually do Pcnn in prone position. So the image we will see in fluoroscopy will be seen in the prone film.
Okay. Anything else of the prone film?
Sushant?
If the ureters are not seen on the supine, then they do the prone film also to see the ureter.
Many times you will see upper ureteric stone, you do IVP, they were not seen around 15 minutes, 20 minutes. But once you do a prone film, they will be seen. So, what next? You wanted CT. This is the CT image. Okay. Now again asking, what are the additional information you want to gain from the CT? This is the plain CT was done.
Sir, the condition of the spine and any bony abnormality. Okay. And the Hounsfield
Does
limit
the
of the
spine looks normal in this case?
No,
there is some background noise from somewhere. Please mute whoever has not muted their mic. Please.
Again, one thing was missed in the X-ray also. The spine is
scoliosis.
Scoliosis is there. Okay. Next, spine. Then what else you want to see from CT?
So the Hounsfield unit of the stone, the exact size of the stone,
Okay.
and the skin to stone distance.
Okay.
And
the relation of colon also.
Okay,
yes,
Manoj has already said
colon.
that colon. Anything else you want to see? In the USG, there was not much hydronephrosis. That was cortex only. Okay, you can see it, confirm it in the CT. The cortex is good. You can also see whether there is an inflammation associated with the stone or not. If the stone is in the pelvis, the periureteric inflammation may be seen. In this, some amount of fat stranding is seen here beside the ureters. So, these also will give a clue. Okay. This was a 3D reconstruction. Reconstruction models can also be seen. You can see there is extension in the upper pole, slight extension in the mid pole, and slight in the lower pole. Can anyone define what is the complete staghorn and partial staghorn?
If there is stone in pelvis and more than 2 calyx are involved, or more than 80% of the calyx are involved, then it is complete staghorn.
Okay.
And if the stone is pelvis, then at least 2, then it is partial staghorn.
I think a single calyx involvement is a partial. If it is more than 1 calyx, then it's a complete stag. This was the CT report. A Hounsfield unit of the stone was in the center, it was 1400, and the periphery, it was 1000. Okay. What's the next thing you will do? You have got all the investigation. Would you like to investigate more, or you want to go to management?
Regarding her blood sugar, it is controlled or not, I want to see.
Blood sugar was no. Random blood sugar was 123. Her HbA1c is 7.1. She has a good control of her diabetes and hypertension.
Sir, PTM and INR was also normal.
Yeah, PT-INR was normal.
Yes, sir. Then, sir, we'll
get a cardiac scan and we'll start antibiotics because the culture was positive.
Okay. You want to treat the UTI first?
Yeah.
How many days you will wait? Suppose we are treating the patient, the culture is positive. Again, after 7 days, 14 days, you ask the patient to come again. Again, the culture is positive. So how long you wait?
$7 days, sir. After starting the antibiotic, we will have to wait for the culture-specific antibiotic. We'll wait for 7 days at least.
Sir, panel members, the seniors, can you guide us with this? If the culture report is positive repeatedly, even after 7 days, at 14 days, after 3 weeks of waiting, what should be done next? Whether we should proceed for the surgery or we should wait?
Yes, Nitish, this is a very important question, and a lot of times this is asked, especially if in case of obstructed kidneys. So the relevance of culture is different for obstructed kidneys and non-obstructed kidneys. People have done studies by random voided samples, and they have done studies by taking the PCN first culture, the fluid that comes out on a puncture on a PCN.
Yes.
So there are very controversial reports. So we don't have to see just the culture. What is the culture? We have to see the patient in totality. So whenever the candidate is asked this question, he should take the patient in totality and not as an isolated, incidence. And what they follow day in and day out. So it is not that in your hospital things would be different and my hospital things would be different. What I want to say is that if the counts are normal, the patient is robust, there is no evidence of sepsis in the patient, there is no fever, there is no flank pain, means there is no active element of acute pyelonephritis. You can always take the patient up in 48 hours. You can start the antibiotic prior to this thing. and you can go in and start treating the patient, because it doesn't make sense to wait endlessly. And we have a literature support for that. And the candidates should go through the literature review and see what is the literature and quote that when they're answering the things. This is my view.
I fully second, Rahul, your view. We have to decide whether the kidney is obstructed or unobstructed. It's not, you have to see in totality, you have to see the total count also. And if you're concerned that you feel that the patient might be in sepsis or going towards sepsis, you can also add CRP to your test. That one thing also is also one indicator of acute inflammation. So rest, what Rahul has discussed, I fully, that is what we actually follow in the clinical guidelines also.
Few more things are being followed, sir, nowadays.
Just one thing. Sorry, Mitesh. The important thing that the candidate has to keep in the mind is that the examiner will not ask to do a PCNL to the candidate. What we want to see is how safe are you with your patients and how you can stay away from litigation. You get my point? What I'm saying now, it is not only about treating the patient. You have to be at the background. You have to be tomorrow if something happens and the patient goes to the court and say, oh, my culture was positive. You did a surgery, and then that is why this happened. So what we want to see is how with literature support, because you should be with the literature support, what literature support you are quoting and what you are following. And that is very important for a candidate, what we want to see as an examiner.
In India, sir, the freelance practice, almost everyone has done in initial years. And most of us were doing PCNLs without seeing the culture, without seeing even investigation. So if we present our reports, then the things might change, because those patients never had any sepsis and they went asymptomatically. So this is
you are correct, but what I'm saying is today is the time, because not everybody has the facility to work in an institute. The literature is very clear on that. Not even for this thing, even for a TURP on a catheter, the literature is very clear on that. That there is no harm. You start 48 hours prior. There should be no element of sepsis. Your counts and other things should be normal. Add a CRP, which Dr. Harpreet Singh has said is very valid question, and then you can proceed. You can always have that. There's no issue about that.
Nowadays, we can also see procalcitonin. So this is also an important marker for infection.
One more marker comes, a neutrophil lymphocyte ratio is also coming up in very good indicator. It doesn't need any much extra cost also. Okay, moving on to the case. So how will you manage?
So once we have started the antibiotic, and as Sir said, there is no any raised found, there's no flank pain, no fever, is absolutely all right. We have done the cardiac fitness, then we'll go ahead with surgery. We'll do left Pcnn in this case.
Okay. Do you want to do anything with antiplatelets or the blood thinners?
In the newer guideline, they have said that mainly the aspirin, if you do not stop also, means we can go ahead. But in this case, means I will stop for at least 5 days.
Okay.
I would like to stop the clopidogrel for 5 days, but aspirin we can continue in the perioperative period.
Okay. Depends on the cardiac. You can consult your cardiologist. Yes, if he says aspirin is important, you continue with your aspirin. If aspirin can be stopped for 5 days, better to stop it. Okay. So how do you want to treat the patient? Everything is managed, says ready and PSA fit.
So we'll go for prone PCNL.
You will go for PCNL.
Prone PCNL, sir.
What PCNL you want to do in this case? Okay, so coming to the PCNL, what are the contraindications when you will not do PCNL on this patient?
If the patient is having coagulopathy, That is raised beta minor, and that is the absolute contraindication, sir. And any active infection or sepsis, then also we will not go for the Pcnn. That first we have to treat it.
Few more things. If there is tumor in the presumptive tract area in pregnancy, these are the things. And the patient with bleeding disorder, anticoagulants must be discontinued. Coming to the next, we have already discussed about urine culture and hematuria. There's a background noise.
Midline मध्ये ना.
Lot of noise are coming, Ranjan. Lot of noise. Please all mute your microphone except the one.
Ruma, please mute everybody excepting the speaker and the moderator. Please. Carry on, carry on. Very good class.
So, which type of Pcnn you want to do? Prone or supine?
Prone, sir. Prone Pcnn.
Okay. Lot of disturbances.
That the purpose is defeated actually.
Okay. So prone or supine doesn't matter until you clear the stone. Okay. What is the tract size? You will select which calyx you want in this case. I will enlarge the X-ray for you. Which calyx you want to go in, and what is the tract size you will select?
Yeah, the extension of the stone is in the upper calyx, in the mid calyx, and some extension in the lower calyx also. So accordingly, I will plan. At least in this case, we may need 2 puncture at least minimum. And the tract size will be a standard tract size, means either 26 or 28. And then I will try to clear all the stones.
Okay.
I would like to puncture the upper calyx.
Okay.
And, we'll try to keep it in one tract, and through the upper calyx we can go up to the pelvis. And
okay.
For the middle calyx, if it is difficult, then we can use the flexible nephroscope, sir, and the holmium laser to completely clear the stone margins.
Any difference if you use laser or lithoclast in your strategy?
So regarding energy sources, there will be no difficulty. But if you want to use flexible scope, then we have to use lasers.
Okay. So in this case, we can go either from point A or point C. I think both will achieve you a complete clearance. Single track might do the job because the angulation is not much from upper or lower calyx. A slight difficulty might be there in reaching the pelvis, but once your guide wire is gone, mostly it will not be there because kidneys are more mobile. It's seen like this, but once you angulate your nephroscope, the kidney's orientation actually changes like this. So it moves. If you have gone from here, you can easily reach the pelvis. It's not much problem. Now you have gone inside, you have cleared the stone. And one more thing about the tract size. This stone is around 3 centimeter. You can clear with mini also and laser. It's not much difference of time. If you are experienced, you can go with normal mini nephroscope. Nowadays, the tract sizes in many cases are not being made more than 20, 22 or maximum 24. So almost we have to forget about the standard that we were using, 28 or 30, unless the stone bulk is very large and it will take more time. The patient is serious. We have to finish the things faster. So go with a lesser size tract so that bleeding will be more. The more parenchyma you tear, the more bleeding you will get. So we have cleared the stone. Now what is your exit strategy? Whether you want to put in a tube or you want to go tubeless or completely tubeless in this case?
I will put both and the PCN. Because his diabetic, large stone burden will take at least more than 1.5 hours to clear all the stones. There will be some bleeding also. So in this case, I will put a DJ stent and a PCN also.
Okay.
Yes, sir.
So this was about the PCNL. Would you like to do anything else in this case? Suppose the patient says, sir, Dr. साहब कोई होल नहीं चाहिए body में, कोई कट नहीं चाहिए, ऐसे ही stone निकाल दो. What you will do to these kind of patients? Can you think of ESWL, RIRS?
Sir,
Or
as the Hounsfield limit is 1000 to 1400, so ESWL will not do our job, sir. So we can think of RIRS, sir, in this patient.
For Hounsfield, the stones, I don't think there should be the option of ESWL.
Okay. Would you go for a sandwich therapy in this case and define what is sandwich therapy?
Sandwich therapy is that first we will go for PCNL and followed by ESWL for some small fragments, and again following the ESWL we will go for another PCNL to completely clear the system.
Can you reverse your answer? It's not correct. The sandwich, the stuffing is wrong. You have put it upside down. ESWL, see, less invasive procedures should not be repeated, can be repeated twice, and more invasive should be done once. So what you want to do is you want to break the stones so that you do invest less time in your surgery and then do a PCNL. If anything remains, you want to do again a ESWL. So this is a very important thing in ESWL, the favorable and unfavorable factors. Can anyone tell what are the unfavorable factors for SWL? One is the stone size in this case. This is not a favorable case.
Well, the infundibular pelvic angle, if it is less than 70 degrees, if the infundibular is less than 5 mm, and if the length is more than 1 centimeter, and if the Hounsfield is more than 1000, if the skin to stone distance is more than 10 centimeters. So these are the unfavorable for ESWL.
Okay. Can you leave the patient on its own on observation?
These are infective stones, so they will need follow-up.
So you can't leave the patient because naturally we will go for renal.
So what is which kind of patients you want to leave?
Dipankar, just to interrupt, Dipankar, why do you not want to leave these patients? What is the literature support behind it?
Sir, because it is seen that up to 50% of the kidney function is lost in 2 years if we leave the patient on his own.
There are landmark papers on the management of stag-on stones. Though things have changed over a period of time, the endoscopy has improved a lot of things, but there are still papers and they have followed these patients up to about 10 years over the period of time and found whatever you want to enumerate. So my opinion again would be that you should go through the literature once again, and whenever you are defending yourself, you should have a literature support for that.
Yes.
Okay, you cannot talk like a consultant because you are a young brain, you're working hard, you are reading day in and day out. You should come out with a good paper. One landmark paper is there for stag-on calculus. If you'll search, you'll find that, and then you can quote that paper while you're defending your decision not to do anything.
If you see the same patient going back, once you saw the X-ray, you said that whether the kidney is functional or not. When you see the USG or the CT, the parenchyma is almost good. There's no thinning, there's not much hydronephrosis, and there was a prompt excretion. So these kinds of patients will do considerably good without any deterioration or that much deterioration in the kidney function. So if some patients are there which they do not want surgery or there's not obstruction, can be managed on active surveillance. So few things are there which should not be done if this for active surveillance. If the patient is on high risk of thrombotic complications and a asymptomatic calyceal stone should be left. Other many situations are there in which you have to interrupt the active surveillance. Would you go for an open pyelolithotomy in this case?
Nitish, 2 minutes to conclude.
Okay, sir.
Just conclude in 2 minutes.
Would you do an open surgery in this case?
Sir, we can go for open surgery if the patient agrees, sir.
We will discuss with the patient all the options, and that also we can do open also.
Okay. So it depends on the patient's decision. The treatment algorithm, I think, again, will be discussed in the next few cases. We'll move on to this. We can do a laparoscopic pyelolithotomy also, the patient wants. Complications, I think the next case or the fourth case will be discussed. So the staghorns can present like this.
So Nitish, very well discussed this case. Thank you. I thank all the students and the audience for very good participation. I will request the next speaker who is coming, since we have a lot of discussion over the history, ultrasound and all things. So keep more time for the management, because let's discuss management also in a lengthy way, because the first part we have given to history and all of the blood investigation and urine investigations, everything. So now let's concentrate more on the management part. And I will invite the next presenter is Dr. Somrendra Poonam from Imphal. His is a clinical case presentation, symptomatic right upper ureteric stone, 7mm stone. And the students are Dr. Siddharth Sathe and Dr. Ankit Sandhu. Over to you, Dr. Somrendra.
Yes, sir. Good morning, everyone.
Hi, Somrendra. I can't see you, man.
Sir, I think you can see me, sir.
You're not very audible. Somrendra, kindly increase the volume. We are not able to hear you very clearly. Speak close to the mic.
Am I audible, sir?
Yes, sir. Better. Go ahead, Somrendra.
Okay.
I'll ask students to introduce themselves first. Dr. Siddharth will introduce, then Dr. Ankit, and Dr. Somrendra will also introduce before starting the presentation.
Good morning to respected teachers. I'm Dr. Siddharth Sathe. I'm a third year MCH resident at Guwahati Medical College.
Thank you.
Myself, Dr. Ankit Sandhu from IPGMR, Kolkata.
Which year, Ankit?
Third year.
Okay. Poonam?
Yes, sir. I myself, Dr. Somrendra Poonam, working as a consultant urologist and a renal transplant surgeon, Caesar Hospitals and the Research Institute in Imphal.
Okay. Start the proceeding. Little loud, Poonam. Thank you very much. Start. Yeah, I feel that there are a lot of senior teachers and very experienced people in the panel. So if you feel that
yes,
sometime moderator is missing any question, if they want to ask, just raise their hand and they can ask the question. I see a lot of good senior people there, so people should get benefited. But kindly, the person who is moderating should coordinate it.
My screen is visible? Hello?
Yeah, Poonam, tell me. I can see your slide. Make it full screen. Make it full screen.
So let me present
the
case scenario. A 44-year-old male with no past history of any comorbid illness presented with right flank pain with radiation to the right groin with 2 episodes of hematuria for 1 day in urology OPD. He had got a history of fever and vomiting was also there. And the past history was there was multiple episodes of passage of stones in the past, and history of lab URS was done 2 years back. General physical examination, the patient was febrile, and other general physical examination was essentially normal, and other systems were normal. On per-abdominal examination, abdomen was soft, and there was mild tenderness in the right lumbar area, and right iliac fossa was non-tender. So at this stage, I want to ask my students, like, what is the differential diagnosis at this present stage?
Since the patient has a history of right flank pain and there's a past history of urolithiasis, my first differential diagnosis would be right renal or a right ureteric stone.
Along with that, is it only the ureteric stone, or along with that, what you want to add?
So on examination, the patient is febrile, so there might be a component of acute pyelonephritis also.
Yes, because there was mild tenderness in the right flank region on examination, so there might be acute pyelonephritis. Yes, you are right. So what is the first investigation you want to order as a consultant when you become a consultant?
Sir, I would start with routine blood investigations. I would like to have a CBC, electrolytes, and renal function test, and a urine analysis.
What about urine culture? Would you like urine culture?
Yes, sir. Urine analysis and urine culture.
And what about imaging?
Sir, I would like to have a ultrasound of the KUB as an extension of physical examination.
Okay. So it is the ultrasound of the patient. There was mild hydronephrosis on the right side, and there is a right upper ureteric calculus of around 7 to 8 mm. And this is the blood investigation. And as you expected, since there was fever and pyelonephritis, total leukocyte count was 15,000, and creatinine was also mildly raised to 1.5, and uric acid was 8.1, and routine examination of urine shows RBC of 15 to 28 per high power pill, and per cell was 10 to 12 per high power pill. And urine culture was showing E. coli more than 10 to the power 5 in colony forming unit. And at this stage, what do you want to do with the patient? And will you go for definitive management, or what do you want to do?
In this case, we would like to admit the patient and start a culture-specific antibiotic, and we would like to give a digestion, and we'll wait for 7 days, and then we'll go for a definitive management for clearance of the stone.
Because this culture-specific antibiotic will come after 3 days of incubation. Before that, what type of antibiotic you want to start?
So ceftriaxone is, as is sensitive ceftriaxone, so ceftriaxone 1 gram BD will be sufficient for the patient along with the digestion.
Will you go directly go for digesting, or you want to wait for a while?
So under antibiotic cover, we can go for the diversion, because until unless there is obstruction is not relieved, patient will not improve that much symptomatically. Only on the basis of antibiotics, the patient will not be recovering until unless we relieve the obstruction. And we should wait for the definitive procedure so that the patient may not end up in urosepsis. And once the obstruction is relieved, patient is tried, then we should go for definitive management after waiting period of 7 days.
My question is whether diversion is 100% required, or can you wait with antibiotics or not?
Pardon, sir?
I mean, diversion is 100% required, or can you wait without the diversion with antibiotics?
So as the patient is symptomatic, sir, counts are raised, and their features of sepsis, sir, creatinine is also rising. So we should go for diversion in this case, sir. If it had been no sepsis feature, then we could have been, sir.
But the patient is hemodynamically stable. And after giving antibiotic, 2 doses of antibiotic, patient started improving without any deterioration of signs and symptoms.
So if the patient improved on the antibiotics and there is no flank pain, counts is decreasing, and then sir, we can go for the definitive management after 48 to 72 hours.
That's what my question was, like, you have directly gone with this stenting. So if without stenting also, can we do it or not? That's my question.
Yes, sir, we can do it without DJ stenting also.
Yeah, so the patient was given option that he wants to be treated at home. So after 2 shots of antibiotic, his conditions became stable, and he remained hemodynamically stable, and he wanted to go home, so he was sent home, and he was advised with for 7 days course, and in 7 days he was called in the OPD, and all blood parameters and everything became normal. After that, he was taken up for right URS under and during the process, stone up migrated and RRS was done and stone was retrieved and digestion was placed and stone analysis was showing uric acid. So my question is, what are the further options of treatment rather than URS? As the patient became febrile after treatment of antibiotics, and what are the further options of treatment you want to explore?
Sir, before saying that ESWL would be an option, I would like to have IVU for this patient, sir.
IVU?
Yes.
Will you go for IVU or CT urography?
We already have CT urography, sir. So we won't go for IVU.
CT urography, since like I have gone for CT urography and this is a picture. So will you go for ESWL or URS? That's my question.
Sir, if the patient is asymptomatic and the urine culture is sterile after 1 week of antibiotics, sir, I would go for ESWL.
And what are the factors you want to look for, whether you go for ESWL or URS?
Sir, we look at the size of the stone and the Hounsfield unit on CT scan. Sir, we also look at the excretory film if the stone is completely obstructing and whether the dye is draining beyond the stone.
So, we have to consider all the factors like stone factors, like size of the stone, location of the stone, whether it is obstructing or not, and like clinical factors, like patient is having sepsis or not, and patients we have to see, and anatomic factors like whether there is a presence of UPDO and renal ectopia, and other factors are also to be considered. And whether there is any option for medical
If the patient would not have been under sepsis or asymptomatic, profoundly symptomatic, then we would may consider for the medical expulsion therapy for 4 weeks. Because stone size is 7 meter up to, though the rates are low, but if the patient would have been non-symptomatic and the pain is tolerable, then we would have gone for a trial of MET.
What is the guideline for this one medical expulsive therapy in proximal ureter?
If the stone is non-obstructive, non-infective, and the symptoms are tolerable, then we can go for MET therapy for proximal ureter stone. Though the stone, we have to consult the patient that the chances of stone clearance is quite less, about 40%.
Is there any literature support for MET in proximal ureteric stones? Because most of the literature are for the distal ureteric stones. Is there any literature support for proximal ureteric stones for MET? Hello?
Literature support, don't remember right now.
Most of the literatures for medical expulsive therapy, those who get benefits are for distal ureteric stones. But still, we can go for proximal ureteric stones. There are some literatures. and supporting for it, but chance of expulsion and the time for expulsion of the stones are typically less for stones in the proximal ureter. So while doing this URS, the patient, the stone has gone up, and if suppose you do not have RIRS facility, then what will you do?
We can go for some mini Pcnn as the size of the stone is small, so we can go for a mini Pcnn and we can remove the stone, sir. If we don't have RIRS facility with us.
And what are the complications you can find during RIRS of this type of stones?
So during RIRS?
No, during URS, what are the types
Yes,
of, what are the complications you can find?
Sir, during URS, the complication like in this case, the stone was lost stone, or there may be, sir, ureteric perforation, or sir, if stone have then, sir, excessive bleeding if the stone has been impacted and we perforate the walls.
Suppose if while accessing the ureter, if you can't access the ureter, the smallest size available you are in your hospital, what will you do?
So we are not able to hear you, sir.
We are not able to hear you actually.
Hello? Hello? Can you hear me?
Yes, sir.
Hello?
Yes, sir. Yes, sir. I can hear you
now. Now audible, sir.
Can you hear me?
Yes, sir.
Suppose with the smallest size available if you can't access the ureter up to the stone, what will you do?
So we put a guide wire and we'll like to negotiate. If even with single guide wire it is not, then we can put a second guide wire and we would like to negotiate our URS up to the stones.
Suppose even in spite of all maneuvers, like you can
yes,
access the ureter stone location, then what will you do?
We put a stent then, and then
we can go for the anti-gates. We can give can go if with all maneuvers the retrograde approach is not feasible. We can go for an anti-gate approach, and we can go do a puncture in the kidney. And if we have a facility of flexible nephroscope, then we can go up, go toward that and can remove this also.
Or what is the second option?
Second option, if we are able to put the stent, then we would like to keep a stent for 7 days, and the ureter will be dilated, and we can again go back with URS.
Sir, other senior members of this panel have asked questions. Hello. Hello, Harpreet sir.
Samarendra.
Sir.
Where is the inhibition of putting a double stent and doing a lithotripsy? Where is the problem? After you treat the sepsis, put the DJ and 7mm stone, when the creatinine settles down, count down, where is the problem in the putting a doing a lithotripsy here? Ask
sir,
them.
Yes, sir. So please answer the questions. What Sir Shivaji has asked the question.
Sir, putting a DJ stent and doing the ESW is also an option, but it has been seen that results with and without putting a stent are equivalent. So we can proceed with ESWL without a stent also.
No. Putting a DJ stent in this case was because of urosepsis, not because that DJ stent has to be put before the ESWL.
True.
Yes, sir. So, sir, if we are stenting the patient before giving 1 week of antibiotics, and after that the patient is presenting with normal counts, then we can go for an ESW. The patient is already on a stent.
What about the stone dissolution therapy in this case?
Sir, if we have a stone analysis, then we can go for stone dissolution. If we have
the Huntsville unit, the CT has been taken, and Huntsville unit was found to be 300, and in urine analysis, pH was 5.5, and uric acid was raised to 8.2. And what are the medications you want to prescribe if stone dissolution is contemplated and the patient wants it?
Sir, in this case, since the stone is causing hydronephrosis and fever, it has already been symptomatic, sir. In that case, clearance of the stone surgically would be more advised.
Yeah, but the stent has been put and the patient insists on stone dissolution therapy.
So then we can go for, sir, alkali it's most like in probability uric acid stone. We can go for alkalization of the urine, and we can start, sir, allopurinol, xanthine oxidase inhibitor. So that will lead to, sir, dissolution of the stone over the time, sir. And
will you start febuxostat or allopurinol?
So nowadays, febuxostat is preferred over allopurinol. So earlier it used to be, sir, allopurinol.
What are the treatment targets you want to achieve in a uric acid stone?
We should keep pH of more than, sir, 6. If urine pH should be.
So uric acid stone dissolves at what pH of urine?
Pardon?
Hello.
Yes, sir.
Uric acid for dissolution of uric acid stones. What pH you want to keep? The pH below the patient should be.
Sir, you're not being audible, sir.
For dissolution of uric acid stones, what pH of the you want to keep? What is the urine pH you want to achieve for the
Sir, for dissolution of uric acid stone, the target urinary pH should be between, sir, 6 to 7, sir.
No, I think I differ with you. It's 7 to 7.5.
So it's very unlikely to reach about 7, and it more predisposes the patient for the formation of calcium phosphate stone. So we should try to keep it between 6 to 6.5, sir.
If it is more than 7, 7.5,
so to keep it, more than 7.5, it's firstly it is quite difficult. Second, it will lead to, sir, precipitation of the calcium phosphate stone, sir. So it will invite more complications than treatment.
What are the 3 steps you want to have for this patient for dissolution of stone? What are the other steps?
Sir, we'll ask him to increase his urine intake, so that his minimum urine output should be more than 2.5 liters per day. Second, we can advise him dietary modification to have a diet low in, sir, uric acid, like to avoid animal proteins. And third, we can go for urinary alkalization with potassium citrate. We can start on like febuxostat.
What are the diets you want to advise to avoid for this patient?
Sir, we would like to advise him to limit his animal protein intake, basically, sir, and other foods that are like rich in uric acid, like pulses and all. We have asked him to restrict them, and sodium intake should be less than 2 grams per day, sir.
Sir, you can ask more questions, sir.
Yeah, I wanted to ask them one thing. This is a very interesting case and most commonly seen. Suppose we saw the success story. You admitted the patient, creatinine coming down from 1.5, count coming down. Now what happens? The count going up, creatinine going up, and you are not winning. What is the other option you have got? About diversion, I'm talking about.
If DSNs fail, we can go for the percutaneous nephrostomy.
With ultrasound guided or fluoro guided?
Ultrasound guided will be sufficient.
Yeah,
sir.
So sufficient. You have to go for ultrasound guided.
Yes,
so that is an option you have to keep to play safe. If it is not improving, that is in your treatment option. And when you put a PCN, sometimes that can actually propel the stone downward sometimes. But one thing is for sure, your literature will say MET is for less than 2 millimeter stone in the lower ureter. Upper ureter doesn't support much of a MET in the ureter. Okay, just keep in mind on that one. Okay, that's a very important option.
While doing PCN, sir, fluoroscopy is also, I think, definitely required while doing dilatation also. And
yes.
Only ultrasound is not like sufficient. Because how much dilate will be detected by fluoroscopy? CM.
Okay.
Yes, sir. We can take more questions from other panelists, sir.
Dr. Somrendra, what 7 millimeter upper uretary calculus? What was the final consensus of the house? What is the ideal treatment for this patient who is not in sepsis, 7 mm upper uretary stone?
Sir, we have to take into consideration about patient expectation and to discuss the problem with the patient. If the patient wants ESWL, we can definitely go for it. And according to the literature and according to the EAU and AU guidelines, 7 mm less than 10 mm stone, upper uretary stone, we can definitely treat with ESWL or URS. There is the stone expansion rate is all the same. So it all depends on like what is the patient expectation, what they want, and what are the comorbid illness, whether the patient can undergo surgery under anesthesia. This is the concern.
So Dr. Somrendra has made a very important point, because nowadays we don't talk of extracorporeal shockwave lithotripsy. The 7 mm stone is amenable to all sort of management which you can think of. You have to discuss all the options with the patient and then take a call what the patient expectations are, because now it's not that what we want or what we are comfortable. You have to give the options and you have to discuss so you can customize the treatment accordingly to the symptoms, present patient expectation and your experience. Rahul, you have put a question. I see that any one of them, Ankit, can you take this question? Dr. Rahul has put in the chat box that how will you monitor the pH of the urine?
Sir, nowadays, sir, dipstick pH monitoring devices are available. We can simply put the pH strip in the urine sample and we can monitor the pH.
What time of the day you should check the pH of the urine? You tell the patient you check the pH of the urine. What time of the day?
First morning sample to be discarded, and next sample we can same time, same day, we can ask the patient to monitor the pH.
Random sample has to be taken.
Yes, sir, random sample.
And what are the contraindications to ESWL in upper ureteric stones? When you say no, we don't want to do it, we want to do something else.
So if the patient has untreated coagulopathy, if the patient is pregnant, then so if anatomical factors like ectopic kidney and the patient, we cannot target, focus the stone. The other side.
Distal obstruction.
Harmful unit of stone more than 1,000.
Exactly, distal obstruction. And if the stone is impacted at side, if there's a proximal, lot of dilatation is there and there is no fluid level between the stone and the ureteric wall, there are the chances when your ESW is going to fail a lot. It is not only the size of the stone is one of the criteria, it is not the sole criteria. If you believe that your stone is impacted, there is a lot of edema there, proximal dilatation is excessive, then the chances are that it may fail. And this you have to bring it to the knowledge of the patient. Then let patient decide what is to be done. Okay, that's fine.
Adding one more point to what Rahul ended there is also see the renal function. I have seen people creatine 2, creatine 3 also giving that. So look for the creatine also, look for the renal insufficiency also. It may be a CKD kidney also. Or upper ureteric stone people have given, though the incidence is now less now these days, but there's also one of the contraindications or one of the, it's not proper to give it a ESWL because the kidney is not functioning, it will not clear the stone. So you have to see whether it's a functioning kidney which can clear the stone.
Very valid, very valid point.
Yes, sir.
Any questions, Shivaji Dasha, Kalyan Sarkar, Ranjan De sir, Ashu? I see Ashu also. Nitesh. Any postgraduate student want to ask any question, want to clear any doubts with the teacher?
I have got a question.
Yes, sir.
The similar scenario with 12 weeks pregnancy, how will it differ your management? The same type of stone, yeah.
So in that case, we would like to go for DJ stenting and will defer the definitive treatment till delivery, sir.
How do you put a stent?
When?
So DJ stent can be put under local, sir. And,
how do you know that the DJ stent is in the ureter and not outside the ureter? Same packed stone, dilatation is there. How do you confirm?
So that we have to do with the fluoroscopy, sir, to confirm X-ray, sir. But that we can hide the we shield.
The patient is 12 weeks pregnant.
So there is a caveat. Is a 12-week pregnant. That's what Doctor. It's a googly from Shivaji.
Yesterday, Dr. Harpreet was telling you, that the harmful exposures, everything was discussed yesterday night.
Yes,
and
sir.
Today morning, you cannot give that answer. You use fluoroscopy. Is not the answer. Okay.
Ankit is only present.
Yes, I am present.
So, ultrasound to.
We can use ultrasound, sir, to confirm.
Ultrasound, yes, but see. The important answer should be that it should be done by the experienced urologist.
Okay.
Even if you have passed out, you get one stone such like that, don't hinder into that, because experienced urologist with this putting of the wire will understand whether the wire is going or not. If he has a give or he is not very comfortable, you withdraw the wire, and putting a PCN is much more safer option if you have any doubts under ultrasound guidance than going for a blind stenting.
Absolutely. And what sort of antibiotics you will choose in a pregnancy situation, which is the safer antibiotics?
The ceftriaxone can be given.
Okay. All right.
Even piperacillin tazobactam is also safe enough.
Yeah.
And
Yes,
if the patient is having frank sepsis, what is the which option will you go for, PCN or DJ stenting? This one is a better option.
The PCN would be a better option if the patient is
No, according to the study, there is no difference at all in the outcome. So whether you do a PCN or whether you do a PCN, it all depends on the availability of resources and expertise.
But with the caveat, that study, have you read that study by Jean Dina-Rosette? It's a prospective randomized trial between a DJ stenting and a PCN for pyonephrotic kidneys. आप लोगों ने पढ़ा है सिद्धार्थ and Ankit? Have you read that? If not, you should read it. There is a caveat in that if there is a frank pyonephrosis, the patient gets better earlier with the PCN. There is no, in the long term, there is no difference, as Dr. Sumendra has said. But for the early recovery, the PCN is a better option than a digestion for faster recovery. But otherwise, you should read that study. That is a very nice study for you people to defend in the exam.
Yeah, it's always safer to say. I mean, nobody can deny that.
But we always feel that PCN is always better because it trends well. But as the study says, it's all the same. And we have to see the situation also. During our MCH days in PJ Chandigarh, we did all those patients who come in the night time, we finish off with PCN. Because to take under local anesthesia in OT is a commercial procedure for us. We have to ship the patient to OT and there will be no one in the OT and you have to do everything by yourself. So we used to say to the consultant that there is a full of us and we have done PCN. So consultant also used to get happy. So therefore my question is, my condition is you have to be, see the situation also.
Okay, one question from my side, sir, if I am allowed to.
Yes, please.
Please go ahead.
If in the same case that Dr. Shivaji Basu sir said, second trimester pregnancy, a periureteric stone, and if you decide for surgery in that case, in a dire situation, what kind of energy source would you use for disintegration of this stone?
Pneumatic and laser has been found to be safe and in the second trimester of pregnancy.
Okay.
Sumendra, I think you've done well. And I think this aperitic stone is a very common presentation. It generated a lot of questions and debate. I'm sure this is not the end of it. there are scenarios which can be created, and Ankit and Siddharth has participated very well. So I will hand over I will invite the next speaker, and next speaker is Dr. Sandeep. His bilateral 1.5 to 2 centimeter stones and a recurrent stone formation in a young man. And Dr. Dipankar Sharma and Dr. Eshansh Khare are the students. So I will request Dr. Dipankar and Dr. Eshansh to introduce himself. Then Dr. Sandeep will introduce himself. And I will request Rahul to take the moderation from here. Rahul, can you take the moderation from the last two cases? And
about the third thing would be about the complications. I'll just share the slide. Just a minute.
Rahul, yours is fourth one. Rahul, Sandeep will be presenting first. After that, yours. Sandeep, are you there?
Hello.
Yeah. Sandeep is there.
Yes, sir, I'm there.
Dipankar Sharma. Yeah.
Yes, sir.
Eshansh.
Yeah. Good morning,
okay,
sir.
Yeah. Please introduce yourself one by one, and then Dr. Sandeep will introduce, and then start the presentation.
Good morning, sir. I'm Dr. Dipankar. I'm third-year resident from Apollo, Kolkata. Good morning, respected teachers. I'm myself, Dr. Ishansh Khare, third-year PDT from IPGMR, Kolkata.
Dr. Sandeep, over to you.
Thank you. Good morning, everyone. I am Dr. Sandeep Gupta, Associate Professor, IPGMER, Kolkata. I believe all of you are there who are supposed to be.
Everybody is there, Sandeep. You can start your presentation.
Fine. So, yes, sir. We'll be presenting the case on bilateral renal calculation. Is it visible?
We see something moving, but yet to see your presentation.
Okay.
Yeah.
Is it there?
Yeah. Make it full screen. Are you presenting from mobile? Yeah. Make it a full screen. No, it was there, Sandeep. Yes.
Sandeep, are you doing it from your iPad or what? A different format.
Yeah. Are you using mobile or iPad? What are you using?
Sandeep sir, you can share the file to us.
Yeah, you can share the file to the.
I'll send you
the screen.
Yeah, it's coming. Stop share.
Yeah, it was coming, Sandeep.
Now I'll share again. Just 1 minute, sir. Just 1 minute.
तो मोबाइल से कर रहे हो क्या?
हाँ सर. It's mobile, sir.
Okay.
अभी आया?
हाँ आ तो रहा है. अब
आया?
प्रेजेंटेशन लेके आओ.
हाँ अब आ गया?
Yes.
Up.
Okay.
Full screen.
Yeah. Okay. I think now it's okay.
Okay. All right. Carry on.
Okay, sir. Let's start. So this is a 35-year-old male patient. He presented with bilateral flank pain on and off for 6 months. Right-sided pain was more as compared to the left side. So, Dr. Ishansh?
Yes, sir.
Will you please give your differentials for bilateral flank pain in a 35-year-old male patient?
Sir, being the stone disease common, I would like to place, first of all, bilateral stone disease, renal stone disease as my first differential diagnosis. Second diagnosis will be maybe patient may be having bilateral PUJO, and that the rest will depend on the detailed past, and the rest on the basis of this chief complaint, I would like to place these two diagnoses now.
Anyone else would like to add any other differential at this stage of bilateral flank pain?
There can be cystic diseases, sir. And also we have to rule out musculoskeletal disorders.
Like?
Sorry.
Yes. So, yes, the idea is that we should not be focused at this stage only with urinary, diagnosis. I mean, urological. There may be, as he said, there may be some non-urological issues also the patient may be suffering from. Because remember, we are just in the initial stage of our presentation, and we should not make the examiner realize that we know the diagnosis. Okay. So
yes.
the discussion should proceed in a way where you lead the examiner to the diagnosis and not the other way. Yeah. So fine. And the differential should always be in the order of probability. The most common should always be told first. So as Dr. Ishant rightly said, bilateral renal stones as the first diagnosis. So the pain was dull aching, non-radiating, and not related to any posture, aggravates on physical activity, relieved with medications. He also had a history of vomiting, 3 to 4 episodes, dysuria, passage of stone 1 month back, 1 episode. So at this stage, what would you like to know? Anything else in positive history or anything?
Sir, is there any history of fever?
Well, no history of fever. So the negatives I've shown here. Anything else you would like to ask?
So any history of trauma in previous past history?
No. Why trauma you want to know, Dr. Ishant?
Sir, actually, my colleague has, if we are making a differential diagnosis of a musculoskeletal pain there, maybe he was having some trauma at the back. So I just wanted to rule out that.
Fine. You mentioned your second differential as what?
Bilateral, maybe it's a bilateral PUJO.
PUJO. So what history would you like to know in case it's PUJO?
So in most of the cases at this age of age, in adult, it simply presents as an asymptomatic case. On incidental finding, we can find a PUJO. But if the patient has a gross hydronephrosis, or the patient had a history of, if patient had a history of fever, if we would have done a renal investigation, and then we could have found out incidentally that patient may had. Secondly, if patient had a grossly enlarged hydronephrotic kidney secondary to PUJO, and the patient had some trauma, patient had history of hematuria, then we could have suspected that it might be could have been a primary PUJO. That may lead to.
Any other typical history of PUJO?
The patient may also present with an abdominal lump in case of enlarged hydronephrotic kidney.
Okay.
And,
anything else?
And
some
on
crisis.
and off. So diabetes crisis may also present with a diabetes crisis when a large amount of gush of, when patient had a pain, then a large amount of patient passes a large amount of urine, then a pain subsides.
Yeah. So you should have mentioned that whether he's having such kind of history or not.
Yes. Yes.
Especially since you mentioned bilateral PUJO. Okay. Can GUTB be one of the differentials?
Sir, it may be, but sir, since the patient had no history of fever in the past and no such history of any finding history of any pulmonary tuberculosis or weight loss or loss of appetite, anorexia, But we may keep it as a case because it is endemic in our country. We may keep it as a, it would be our last differential diagnosis.
Yes. So if examiner asks you anything else, you may add this also as one of your differentials. Okay. Anyone else? Would you like to add anything or ask anything in the history?
No, sir. A patient only had one episode of passing of stone.
Yeah, that too 1 month back, single episode.
So right now patient is not having any dysuria and fever. Patient just having a pain only.
Yes, his main complaint and only complaint is mainly pain.
No, sir.
Okay.
Yes.
So these are some general physical examination findings. And per abdomen, tenderness is there. Other than that, nothing else. Can we proceed?
Yes, sir.
So this is the urinary culture. So what important findings in routine and culture would you like to see? Important things you would like to see. Dr.
So in
Sandhu is there? Who all are presenting this case? Ishansh and Sandhu, right?
No,
sir.
No,
me, sir.
Dipankar Sharma.
Okay, okay. So only two of you.
Yes, sir.
Yes, sir.
Okay, so Dr. Dipankar, would you like to?
Yes, sir.
You would like to see what important things in urinary in a case of stone?
So we'd like to see the pH of the urine, presence of pus cells, RBCs, and as well as presence of bacteria if there is it is seen or not. Nitrites as well as leukocyte esterase will also give us some idea whether there is any active infection in the urine.
Okay. One important thing you have not mentioned.
So crystals or casts.
Yeah, crystals. See, in this slide, I have deliberately not put crystals because I wanted you people to mention it by yourself. So in which type of stone?
So the shape of the crystals. Yes, sir.
Yeah, I mean, shape of crystals. Yeah.
So the shapes can. Please go ahead.
Ishansh, let Dr. Dipankar speak, please.
So it can be envelope shaped. It can be needle shaped in bruchite. It can be amorphous in case of cystine, and also in the case of uric acid stones. It can be dumbbell shaped and coffin lid shaped in struvite stones.
Yes, good. Ishansh, anything else you would like to add?
Sir, actually, so it depends on if there is a calcium oxalate monohydrate, then it is. It depends on the shape. Then it is enveloped, dihydrate, then it is coffin. In cystine, it is hexagonal. In carbonic apatite, it is amorphous.
Yes. Okay, tell me one thing. Which is more hard? Calcium oxalate monohydrate or dihydrate?
Monohydrate.
Why?
Because it is more impact, sir. The structure, because of the structure of that molecular structure.
No, see, dihydrate. So double
Bonds
hydrogen makes it small. Softer. Okay. Okay. Then urine culture is sterile. These are some of the blood parameters. Creatinine is normal. Urea is normal.
Yes, sir.
So what would you like to do next, Dr. Ishansh?
Sir, in this presentation, I would like to also know the, since the patient had passed stone in the past, so in the preliminary investigation as a protocol for abbreviated protocol for this patient, I would like to know the serum uric acid level as well as the calcium level of the patient.
What are the indications of metabolic workup?
So the indications for metabolic workups are for the
I think there's a lot of background noise coming from one person. Maybe please tell him to mute himself.
Everyone
You getting some noise?
mute yourself except for the speaker and the presenter.
I think someone is in the chamber. Yeah, much
Yes,
better.
sir.
Go ahead, Sandeep.
So the indications
Yes.
are, sir, high stone former, and the patient had a family history. The patient had undergone any GI surgery or any medical conditions, GI medical conditions, or patient has an unexplained osteoporosis. Patient has already a known case of hyperparathyroidism, or patient has a or a first-time stone former if he wants to get a workup done, and all the pediatric patients. These are some of the indications for metabolic evolution.
So is bilateral
Sir, metabolic
stone
syndrome.
indications?
Yes, sir.
Bilateral renal calculi, is it an indication for metabolic workup?
So, if the patient if the patient would have been a first-time stone former, we should advise the patient to go for it, and if he insists, we should do it.
Okay. So what next would you like to do in this case?
Sir, considering all the calcium and uric acid and all the blood parameters and urine parameters normal, and I would like to go for the radiological investigation, and I would advise the patient for an ultrasonography QOB with PVR.
Fine. So this is the image of USG.
Sir,
how do you identify stone on USG?
Sir, posterior prostate shadow will be seen just behind the stone. So on that basis, we can identify that there is.
Please speak nicely. What will you see? Posterior acoustic shadow will come later on, but first what you will see? Dr. Ishansh?
Hello. Yes, sir.
Yes, tell.
Sir, hyperechoic and hyperechoic shadow.
Hyperechoic focus having posterior acoustic shadowing. Okay. So remember, all hyperechoic white structures are not stones on USG. Okay. Fine. So can you read this USG?
Sir, the side of the kidney, we cannot say that's right or left.
No problem.
But
okay.
In the first film, we can see two hyperechoic lesions with a single posterior acoustic shadow. And on the second film, again we can see two hyperechoic shadow, probably two. And I'm doubtful.
Yeah, doubtful about the posterior acoustic shadowing.
Yes,
fine.
Yes.
Any hydronephrosis you are able to appreciate?
So in the first film, we can see the grade 1 hydronephrosis, and in second film also I can suspect a grade 1 hydronephrosis.
Okay. So this is the USG finding. Right kidney shows multiple calculi, largest 12.2 millimeter. Left kidney shows multiple calculi, largest around 1 centimeter. Mild hydronephrotic changes in both kidneys. Parenchymal thickness is normal. So, Dr. Dipankar, can you tell what is the normal parenchymal thickness of an adult kidney?
Sir, 1 centimeter, sir.
Dr. Ishansh, I think yesterday we discussed in class.
Sir, normal parenchymal thickness is approximately 1.4 to 1.5 centimeter. Because the cortex is 7 millimeter and medulla is also 7 millimeter. However, we say yes, it is approximately 1.4 to 1.5 centimeter.
Yes. So normal cortical thickness is around 1.5 centimeters, and corticomedullary differentiation has to be maintained in a normal kidney. So next, Dr. Dipankar, what would you like to go for after USG showing this picture?
I'd like to do an X-ray KUB, sir.
X-ray KUB. Okay. Why X-ray KUB? Just the X-ray KUB, why?
Sir, IVP, sir, actually.
Yes. So, I mean, a contrast study, right? You would like to do.
Yes, sir.
We have discussed in the first session, I think, the contrast study is definitely required. Okay. So, which contrast study would you like to go for? What are the normal available contrast studies for renal calculi or any?
So we
have
IVP and we have CT urography, sir.
Fine. So, which one would you like to go for?
I would like to go for CT urography, sir.
Okay. Yes. If you have been given both the options, definitely you should nowadays you should go for CT urography. Okay. So here in this case, we have first done a IVU. So what is the first film of IVU, Dr. Dipankar?
It's a scout film, sir. It's a non-contrast film.
Yes. So what are the things, and normally in IVU, in what duration the plates are taken? Normal standard IVP. After scout film, what is the next film taken?
So around 15 minutes, 5 minutes, then 15 minutes, and then delayed films are taken, sir.
That's all?
And followed by a post-void film.
Sir,
Dr. Ishansh?
So scout film, then at the 5 minutes, 15 minutes, 25, and delayed, then a full bladder film, then lateral film, and a post-void film.
Okay. So, can any one of you read the IVP?
So on the
can you see now? I've enlarged it a bit.
Yes, sir. So on the right, in the scout film, on the right kidney, we can see a single stone. On the left side, in the scout film, we can appreciate 2 stones. And in the IVP, both the kidneys are excreting the contrast, and in the third cut, in the second, sir, can we see this scout film? Yes, sir. Sir, in the in the second phase, probably the 5 minutes, we can see that both the kidneys are draining the contrast well, and in the inferior calyx on the right side, we can see stones on the second film, and on the right side, on the left side, I can probably see a filling defect on the left side, probably in the lower calyx.
Okay. What about hydronephrosis, Dr. Dipankar?
Not significant hydronephrosis is not seen, sir.
Yes, right. So the cupping is more or less maintained.
Maintained.
So the IVU showed bilateral multiple radiopaque shadows in renal areas and normal excretion of dye from both the kidneys. So next, actually here what has happened is he already had a CT done from outside. So we would not have done a CT. So let's discuss a bit about CT scan since he has already done it. So do you think a CT should have been done in this case after IVU, or just IV would have been enough?
Sir, I think we may have, in place of CT urography, we may have simple NCCT would have sufficed for this patient.
What is your idea of doing an NCCT KUB?
Sir, basically, if we are planning for a surgical intervention, we would like to first know the house fluid of the stone, the hardness of the stone. Second, perirenal anatomy, and also the skin to stone distance, as well as the relation of the colon to the kidney. So these are some surgical parameters we would like to know before planning for a procedure, any procedure.
Okay.
So
NCCT would have helped you in this way. The most important thing is the Hounsfield units you will get only on CT scan.
Yes.
Okay. Anything else you would like to add, Dr. Dipankar?
No, sir.
Okay. So these are a few cuts of CT scan. So what is your idea about functioning status of the kidneys based on the IVU and CTU?
Both the kidneys appears to be functioning, sir.
Functioning, right. Remember, we are dealing with bilateral renal calculi, correct? So what is the most important decision you have to make in this case?
Protection of renal function first, sir.
And surgically?
So which side to be operated for?
Yes.
Which side
yes.
to be operated first? Which side to be operated
first? Which side
first?
to operate first? Yes, that is most important. The decision about which side to go for. So how do you decide which side to go for?
So based on function and based on symptoms.
Based on, so which one first?
So as the patient is
the better functioning one first, sir.
So I give you a scenario where a patient complains of pain on the left side much more compared to right, but functional status wise, right is the better functioning. How do you go about it?
So we will be trying to protect both sides. If you are going for an endourological procedure, then probably we'll stent both sides, sir.
Yeah, so one side you will stent.
Yes, sir.
So you will try to protect the better functioning one.
Yes, sir.
At the same time, you stent the opposite side. So that part also becomes protected and he becomes somewhat pain-free also.
Pain-free.
Yes. So CT scan showed large calculus of size 15 millimeter in right lower calyx, which is easily seen on the scout film also in the X-ray. And on the left side, there are few calculi, Hounsfield unit around 1000 to 1100, and size is also about 8 to 10 millimeter in the lower pole calyces. Okay. So how would you like to proceed in this case now? Now, everything is done. Now patient will come to you and tell you, now tell me, doc, what do you do for me? I want to get rid of the stones. So Dr. Dipankar, what will you offer him?
So patient is symptomatic on the right side, and both the kidneys are functioning well with a normal creatinine, as well as there doesn't seem to be a significant infection as well. I would like to proceed with bilateral DJ stenting and right-sided RIRS with laser lithotripsy.
So you mean to say you will take him up for RIRS on the right side?
Yes, sir.
And you will
stent the other side as well.
The other side in the same sitting?
Yes, sir.
Would you like
we will explain to him that, yes, sir. We'll also tell him that it will be a stage procedure. Yes, sir.
Okay. Would you like to give him options, or you would like to offer him upfront RIRS for this lower calyceal 15 millimeter calculus in the right side?
Sir, we will give him options of doing a PCNL as well.
But you did not mention it.
Yes, sir.
You should have mentioned that, sir, I will tell him these options, 1, 2, 3, 4. And then I'll tell him the pros and cons of each. And then I'll tell him to take the call. In today's scenario, especially in exams, you have to tell all the options available based on the size of the stone, location of the stone, and the Hounsfield units and the number of the stone, isn't it?
Yes,
So
sir.
for the right side, what are the things we can offer to this patient? Treatment options.
So we can offer him endourological, that is RIRS, and PCNL as well.
Okay. Would you like to offer him EHWL on the right side?
Because of the Hounsfield unit and the size and the location in the lower calyx, ESWL will be my third choice, but we have to explain that the chances of success will be low.
Very low. So EHWL definitely in this case should be, first of all, I feel not given at all. And if he has come that as we discussed, that he doesn't want any scar mark, any cutting in the body, any invasive procedure, then you can offer him in this case EHWL, but definitely telling him very much that chances are very less and that it may not be successful. So the first option in this case will be PCNL or RIRS on the right side.
So RIRS, sir.
RIRS, okay. So would you like to pre-stent him for RIRS, or in your institute, how do you, you are from Apollo, right?
Yes, sir.
Okay, so you are doing RIRS in your institute, I'm sure?
Yes, sir, we are, sir.
You are. So do you follow pre-stenting and then wait for some days before you go for RIRS, or you just do it upfront? How do you go about it?
So preoperatively, we counsel the patient that sometimes the access might not be good enough to go with an RIRS in the first sitting. In case it is not possible to do an RIRS in an unstented ureter, then we might have to do it as a stage procedure. And with that counseling, we take up the patient. We definitely attempt an RIRS without stenting.
Okay, fine. What are the difficulties you may encounter during RIRS?
First of all, the access itself might be, the ureter might be tight, so we might not be able to access the ureter.
How can you overcome it?
So pre-stenting can be, if patient agrees, then stented RIRS will be much better. And other than that,
now suppose you have not counseled for pre-stenting, you have taken up the patient for upfront RIRS, patient is under GA, intubated, but you are seeing that the thing is not going. So how can you try to overcome?
We can give a good muscle relaxation and then we can do without an ureteral access sheath, although it is not recommended.
Would you like to go for ureteric dilatation?
Yes, sir, we can do so.
Yeah,
for the lower ureter.
Yes, so always ureteral dilators should be kept in hand, and you should always try to dilate with ureteral dilators. Sometimes you may succeed in proceeding. I'm sure Shivaji sir is there. Basu sir?
It has to be in hand always.
Sir,
ready.
Sir.
Ready,
so,
ready.
Sir, if you can throw some light, sir, about RIRS and how to overcome, and if you can ask a few questions, sir.
No, I think they're doing well. Whatever they're saying, it's just a small thing that in extension to that success of a ureteroscopy, you said antispasmodics, you said ureteric dilators in hand. What are the other things that leads to your better success in RIRS? Would you comment on the access sheath size or the ureteroscope size? These are the two important factors. And the pre-stentation, third thing. What sort of size of access should you use generally?
So 11 French, sir.
11 cannot be a size. It has to, no, it's either 10, 12 or 9, 11 like that.
9, 11.
So
yes.
It has to
10,
be like
12.
that. Yes, 10, 12 is the
10,
commonest.
12.
Yeah, one single commonest use, but you tend to go for 9, 11, then you have to have a smaller sheet. So your chances of success becomes high. So three factors: antispasmodics, ureteric dilators, and smaller accession. Good. I just want to ask you one question when you're there, if I may, Sandeep, about
yes, sir,
this.
sure, sir.
When you talked about this, the angle, infundibulary angle, does it depend? I mean, does it influence in your PCNL decision on PCNL or IRS? Because you have kept ESWL aside because of the Hounsfield unit. So you're left
also because it's in the lower calyx,
true.
and also because of the size.
But Hounsfield unit is here because angle is good. Angle is not bad for the ESWL, but because of the Hounsfield unit, you have kept it aside. You are left with mini PCNL and IRS. Does it actually alter your diagnosis or your management scheme, this angle part?
Sir, RIRS may be influenced, but PCNL, I don't think should have a problem with this.
Yes. So that influences your a little bit of deviation from a PCNL to RIRS. If you have to really lower angle, obtuse angle, medially directed, you will lose your expensive RIRS flexible ureteroscope. So that will lead you to the mini PCNL. Anyway, that's very good. Excellent. Carry on.
True, sir. So I wanted this discussion to be a bit on RIRS because I think in the last session PCNL has been discussed nicely. So that's the reason I thought I'll involve sir also in this. So suppose you are through. Now you are into the ureter and your flexi has passed. So tell me, where do you place the upper end of the access sheath? Normally, where is it advisable to be kept?
At the PUJ, sir.
The PUJ.
Good. Very good. Okay. So now tell me, normally, how much time is recommended? Is there any restriction that for RIRS, the size of stone and other, is there anything like that? Or you can just keep doing it?
Sir, for more than 2 centimeters, recommended that we should go for PCNL. For a range of 1 to 2 centimeter, we can go for either RIRS, PCNL, or third scenario, EHWL. And for less than 1, on the basis of the favorable anatomy of the calcium anatomy, we can plan EHWL, RIRS, or PCNL.
Yes. And remember, this location of the stone in the calyx and the angle, it's very important for preservation of your scope, flexi scope, because these are very delicate instruments, and the more you bend it, the more they'll get damaged. Another important problem is that in these lower calyceal stones, don't try to insert your laser fiber with the flexi tip bent. Rather, try to hold the stone with the basket, bring it to accessible position, and then maybe you try to pick up the stone from the lower calyx, bring it towards the pelvis, keep it there, and then lace it. Are you getting my point?
Yes.
Because this saves your scope, this saves your fiber, both. And remember, when you insert a fiber, the flexi becomes more hard. It becomes less flexible. Okay. And a lot of pressure is also generated on the scope and the fiber. So you have to take care of your instruments also. What is another important thing in RIRS you have to take care of to prevent a complication of RIRS? What is the most dreaded complication of RIRS? Ishansh?
Dreaded, sir.
Yeah, what are you scared of post-op?
No, sir.
Sepsis, sir?
Yes. The answer is sepsis. Why?
Because of increased intrarenal pressure.
Yes. So the pressure. So you have to take care of that also in mind because of high chance of sepsis in the post-op period.
Sandeep, you can also ask that since stone in the lower calyx and that reaching there, what they will do, how do we fragment that stone, and whether they will bring it to somewhere else or they will try to fragment that. So
yes, sir. I just now, sir, I told them to bring. So as sir is asking, Harpreet sir. So suppose this stone is in lower calyx. So how would you like to proceed? Suppose your flexi has entered the PCS. So you are entered the lower calyx with your flexi. Now what would you like to do? You are seeing the stone in front of you in the lower calyx.
So we'll use a basket and take it out of the lower calyx and place it probably in the superior calyx.
Yes, good. Superior calyx or the pelvis. Why superior calyx?
The angle of bend of the uterus.
It will be easily accessible for us and the stone cannot run away easily.
Yes, yes. These two, very good. These two important factors. The stone won't run away also while you are lacing. Right.
Sandeep, can I ask?
Sir. Yes, sir.
I had to go. I was disconnected for a time. I'm sure I missed the discussion. Actually, I was going to ask them about the size of the laser fiber use, size of the basket you use. These are two questions through the flexible ureteroscope.
Sir, please answer.
Sir,
Dipankar?
Sir, laser is 200 microns, sir.
Okay. And basket?
So 1 centimeter diameter.
Sorry?
So 2 centimeter, up to 2 centimeter.
2 centimeter? How can it be 2 centimeter basket? It has to be either the width of the basket and the zero tip or not. You cannot use a 5 French basket, can you?
No.
So it has to be basket. It cannot be a 5 centimeter basket like you do it in the normal ureteroscope. So it's at the 0.03 baskets there. Smaller basket, but zero tip. But what I'm going to ask you one thing, Dipankar, just make it a point. You have to frame it in your mind about what Sandeep sir was telling you about this success of the ureteroscopy. It is a nice, protocol there. Protocol is Oliver Traxi has also done the same thing, that you first of all do a ureteroscopy. Ureteroscopy with an 9.88 French, the bigger one, sheet, can give you the anatomy of the path of the ureter, at the same time dilate the VUJ to 9.8. Then your access sheet will go easily. Then you give your Buscopan, then you keep your dilator ready and keep the basket, the access sheet well below the PUJ, as Sandeep sir was saying. And then you use a smaller access sheet. This will all lead to the success of the ureteroscopy, which is so important. There are 3 or 4 protocol, steps you have to keep in mind. And then you will not go wrong. And then you go for the as Sandeep sir was saying, never introduce the laser fiber with the ureteroscope bent, and always think it is easier to have a bent, introduce a Dormia basket or entrap through a bent ureteroscope than a laser. Laser is a much stiffer. And you will ruin the scope. And rest of it you said, relocation is the term. Relocation is the term where you get it out and go to the upper pole, and convenient position, you can do that one. And that is all about the basics of the ureteroscope. I think we all discussed about that one.
Yes, sir. Thank you, sir.
Thank you.
Sandeep, with your permission,
sir, I'm through.
What Sivaji Da has told about right now, he has explained some procedures that how to go about it and how to see it. What is this known as? What is this procedure is known as? That putting a ureteroscope, seeing and doing. What's the term used for this? It's in the Campbell. He mentioned that first you see the anatomy, you put a ureteroscope and then pass everything. What is this known as?
This is known as optical dilatation. So you're going with a rigid scope, you're seeing the anatomy, you're seeing everything, and you see as the ureteroscope is graded. So slowly, it will the last part which you reach is thicker than the front part. So you actually dilate it also, and so it becomes much easier to pass your access sheet. Thank you, Sandeep.
Sir, your take on bilateral RIRS, sir, like as in a case of bilateral renal calculi, single stones, can we go for bilateral RIRS in the same sitting?
Yeah, in a non-infected, uncomplicated case, we can do that one, but I would go for an RGP imaging on the table to see actually the other side needs doing. Suppose it's a calicial stone and there is no chance of it coming out, I wouldn't bother about it. I would go for the one which is symptomatic and which can cause problem, which can come out of the lower calyx to the PUJ. That needs to be tackled first. But bilateral RIRS, I would stent one side and do the other side.
Sir.
It is safer. Okay. Because the chances of sepsis in a whatever the access sheet you give, and if you are not a careful assistant who will put the pressure under the fluid under pressure, that gives rise to an increased intratubular pressure and causes sepsis. So that way, one side do it, another side DJ, do it after 10 days is good enough. 7 to 10 days of rest will dilate the passage. That is my opinion, and you can always stand to that. You have to have the literature support with you. Whatever you're saying, I'm saying, don't take it as gospel truth, but the 7 to 10 days of dilatation is good enough, is in every literature. So you will not go wrong. You will be playing safe. The examiner, not only for the success of the stone management, but from the litigation, from your from legalities, everything, and is a good what is called a work practice. Is a okay. So
sir,
that way.
Sir, one more thing. So bilateral PCNL, should it be ever recommended, sir, in a case of bilateral single renal calculi?
I would do that if it's easy. If it's a both sides of staghorn, I wouldn't do that. If it's a two solitary pelvic calculus or a one-sided, simple calculus, which is, I would do one and I will go for the second one if I, the same prone position. I will put this, the ureteric catheter up there, but I will only wait if everything goes well. You never know. But staghorn, I would not do for that one.
Never.
This brings us to
thank you so much, sir.
This brings us the question: what are the guidelines of doing bilateral PCNL? What should be the size? What should be the time of procedure? And when you should the bilateral? So what are the guidelines? I think Sandeep can ask both the students. I think this is given in the book also when you can do bilateral PCNL.
Sir, so Dr. Ishansh, bilateral PCNL, size-wise? See, we have done a few days back, if you remember, I don't know if you're aware or not, one case of bilateral PCNL has been done in our institute a few days back. So they were solitary calculi. Size was around, Ishansh, as per guidelines?
1.2. Sir, up to 1.5 to 2 centimeter, we can go for PCNL.
Yeah, 1.5 I think is fair enough.
Yes, sir.
Duration-wise,
5 to 2 centimeter bilateral stone, and the time taken is less than an hour's time, and you finish the one side without any problem, without any hematuria, without any difficulty, you can safely proceed to the other side. So,
True.
Do staghorn, as rightly mentioned by Shivaji Da, but you can do go ahead with the simple stones and finish on one sitting.
Yes. So I think, sir, we have had a good discussion. My time is also around 45 minutes.
Just right. Just right. Very good timing.
Arpit, sir, can I wrap up?
Sandeep, very patient from our chairman sir also, and I think we have discussed everything. It's good that you have brought some salient points out of RIRS, which we have failed to discuss in the previous one. And I think over to Rahul for the next session, and he can start the next session.
Sir, thank you so much. Thank you.
Nice job by everyone. Good. So that has left my job a bit easy. So without wasting time,
Yes, I'm just coming out. Yes, sir.
Okay. Thank you, Sandeep. It was nice thing. So now, I'll come to the most basics about which is the last. If any of the candidate reaches up to this place, means he's almost through. And now whatever the examiner is discussing is what does he know extra is basic thing. So am I audible and my slides are visible?
Yeah, Rahul, you can ask Pradeep to introduce himself, and then you introduce yourself before you start.
Fine. Please go ahead.
Good afternoon. Good afternoon, seniors and my colleagues. So this is Dr. Pradeep. I'm a final year resident from RIMS Imphal.
Right, Pradeep. Thank you. Rahul, you introduce yourself.
Yeah. I am Dr. Rahul. I am associate professor in urology department in Government Medical College, Jammu. And Pradeep, these questions and things, you are the only candidate with me. If other candidates also there, they are most welcome, because this is going to be the most important and the wrapping up talk of complications in PCNL. So coming to you, Pradeep.
Yes.
How do you? Why is it not moving? How do you document the complications in PCNL? Now, since you're in third year, tomorrow you will be a consultant, and you'll be doing your own case series and things like that. So how do you document the complications in PCNL?
So I would like to document the complications in the form of the Clavian-Dindo classification system.
Very good. And can you elaborate on that? What is that?
So grade 0, no complications. Grade 1, minor deviation from the usual post-operative course. That includes IV fluids, antipyretics, antiemetics, etc. In grade 2, sir, some pharmacological intervention or blood transfusion is accepted as grade 2. In grade 3, sir, endoscopic or surgical procedures to handle the complication, which may not be life-threatening. This grade 3 is divided into 3A and 3B. 3B is when the procedure is done under general anesthesia. Not under GA, and 3B is when it is done under GA. Then, sir, the grade 4 is life-threatening complications which may require ICU care.
Very good. Very good. I'm very happy that you have said that. There is a finer points, but even if you say like that, it is a very good answer you have given me. And for a PCNL, it is called as a modified Clavian-Dindo. Basically, the Clavian-Dindo classification is for all surgical procedures. So for all the candidates, any question which is asked, the way you have answered is the perfect way to answer. But for PCNL, it is slightly modified. In this, they have a grade 2 and a grade 3 blood transfusion and angioembolization. They are two very different things as a bleeding complication of PCNL. So we have to understand that, and we have to keep it in mind. Similarly, there are other complications like urinary leak, avulsions, and this is the modified Clavian-Dindo score, which has been for this, which is for PCNL only. So I will be sharing my slides with Dr. Harpreet, and he can give it to the council for that. So you have given a very good answer. I'm very happy that you know about this. So how do we classify bleeding in PCNL? So there is a bleeding has happened because I can't show you the bleeding, because God unforbid any of the urologists who comes across bleeding in PCNL, it's very difficult to document that. You need to have a very big heart, because that time the mind just fuses and you are with the patient, because it's a torrential bleeding in PCNL whenever it happens. So how do you classify the bleeding in, if I ask you as an examiner, classify the bleeding in PCNL, how would you classify?
So I would like to classify bleeding into those that are related to the initial puncture, those that are related to the tract dilatation, then finally the exit and the post-operative complications. I can also classify it as intra-operative as well as post-operative, early or delayed bleeding.
Early or delayed. And one more classification is PCNL is venous versus arterial. If you look at the color of this thing, so as you have said, the timing may be intraoperative bleeding, it may be a perioperative bleeding, it may be a post-operative immediate. I don't know whether you have seen it or not. The nephrostomy is absolutely clear, and the moment you take it out, and suddenly the patient will go into shock. So this can also happen. And or secondary hemorrhage, we all know it. The patient can come back after 2 weeks or 3 weeks, and he can have a hemorrhage. So the other component of the PCNL bleeding is a venous versus arterial bleeding. If you see look at the color of the blood, you can very well differentiate between the two, whether it is a venous or an arterial bleeding. So bleeding, what is the incidence of bleeding in PCNL? If I ask you, what is the incidence of bleeding in PCNL?
So the incidence of bleeding
literature,
requiring
with literature support. What does the literature say?
Sir, from 1 to 11%, it
1 to 11%.
ranges.
It's around 3 to, and what are the transfusion rates for the PCNN?
It's around 3 to 5%.
It's much beyond that. Some series have reported up to 23%. And what is the incidence of angioembolization? People require angioembolization?
So 2 to 3%, sir.
No, 2 to 3% is very high rate of angioembolization. It is usually 1 or less than 1%. And why I'm asking you, I'll just give you, this is the incidence of bleeding. Transfusion rates is 3.5 to 23%, and angioembolization is less than 1%, and nephrectomy. It is not that once in lifetime, all of us urologists who are doing PCNL on regular basis would have contemplated a nephrectomy for PCNL, if not for our case, for our colleague's case or something like that. And it is not criminal to do. The patient may take you to the court of law for a criminal activity that he has lost his kidney, but it is not criminal to do a nephrectomy to save the life of the patient. This is not what I say. This is what the literature says. And why do you know? Why do you want to know about this bleeding incidence for your knowledge? How does this help you in clinical practice? Because you are soon going to be a consultant. How does this help you in a clinical practice?
Sir, I may counsel the patient regarding the need for blood transfusion. I may keep adequate amount of blood if required, and I may also inform the anesthetist if.
Not only that, you don't have to counsel. You have to document it in your consent. If you have not done, whenever you pass out, wherever you practice, in an institute or wherever you practice, you have to chalk down these points in verbatim. That will save you a lot of misery. If you don't have that in your PCNL consent, these 4 things, and even mention of nephrectomy, you may not explain, but you have to have that mentioned in the consent that the patient may require a nephrectomy if angioembolization fails. Now the question comes, what is the incidence of failure of angioembolization? Is it successful for all, or does it has its own failure rates?
Sir, it is not successful in all cases. Some patients may require 2 or even rarely 3 angioembolization sessions.
So we'll come to that in subsequent discussion. So this is a good answer. You have prepared it well. So this is the sites of the bleeding. Whenever, like you were saying, this bleeding can start even from a skin incision. You put, because it's a blind incision, you're going to putting a knife there, and it can bleed from there itself. You can hit some intercostal, intermuscular vessels. It can bleed from the intercostal space also. So you should be very careful from where the bleeding is coming. So it can, if the bleeding may happen from the renal parenchyma, from the infundibulum, from pelvic perforation, and even at the time of stone disintegration. If it's an inflamed pelvis, it will become very oozy and it starts to bleed. But they are not very bleedings which one should be afraid of, because they usually settle down. And this is a picture of one of the cases in which the patient had a bleeding. His or her urine was absolutely clear. We did an angio and found that there is a intercostal vessel artery which was bleeding, and the patient was going into, a lot of collection at the retroperitoneum and things like that. So we did an angioembolization, the patient was fine. So you should remember the sites from where it can bleed. What are the risk factors? Now you are in the clinic and you see the x-rays or whatever, you see the patient, whatever things, what prompts you that the incidence is 1% to 5%? Which are the patients you expect the bleeding will be 1%, and which are the patients you expect the bleeding would be 5%?
Sir, I would like to classify these risks into patient-related anatomic factors, medical comorbidities, or stone-related factors. If the patient having anatomical anomalies such as a horseshoe kidney, ectopic kidney, or a pelvic kidney, or calicial abnormality, I would expect more bleeding. Patient having medical comorbidities like diabetes, hypertension, atherosclerosis, or bleeding disorder, I would expect more bleeding in those cases. And as far as stones, I would expect more bleeding in a staghorn stone.
Why in a staghorn stone?
So I may require multiple puncture tracts, and more than 2 access tracts increases the incidence of bleeding.
And what else stone factor in literature which has been mentioned that these stones can bleed more than the other stones? These PCNLs can bleed more than the other stones, and which is very common. You can see if you read the stone guy score, and you can predict that yes, this patient is more probable cause for bleeding and the other is not. The systems which are not dilated, this is a literature fact. It has been documented. That why I'm saying documented is because these all things can help you in future in life. If somebody rubs you the wrong way, it's in the literature. that the systems which are non-dilated are prone to bleed more versus the system which are dilated systems. So you have to look at, when you look at the IVU, which is not a true picture of how the Pcnn will go, but it can just give you a guide. So which calyx you puncture is again predictor of where the bleeding occurs. As you rightly said, single versus multiple punctures. The experience of a surgeon is very important. And is it the position that matters? No. The position supine versus prone, it has been proven it does not increase the risk of bleeding provided you have adequate experience. Provided you have adequate experience. Okay. So, yes. Nice. So again, the solitary kidneys, Staghorn stones, as you said, multiple punctures, inexperienced surgeons were significant risk factors. And this is already in one of the papers in which they have had operated more than 3,000 patients. And they found these were the risk factors, as you also quoted, towards the risk of bleeding in the PCNL. Again, what is the tract size you are using? There's a lot of debate upon PCNL, mini PCNL, micro PCNL, the ultra micro PCNLs, and all this discussion was to reduce the risk of bleeding. So this you did not mention, that is a tract size. You should how you dilate the PCNL, the tract, balloon dilatation versus alkans, because we see only one way of dilatation. Some people do a single step dilatation, some do a serial dilatation. So they are all the factors that lead to the risk of bleeding. The CKD increases the risk of bleeding in the patient. So you have to be very sure of that. And complexity of the stone, as you said, sometimes it may be isolated, calyx impacted, non-dilated system. So these are the patients which have a tendency to bleed more than the other sort of patients. How do you grade the bleeding or hematuria? Can you grade the bleeding or hematuria? Literature-wise, now the bleeding has happened as a complication of PCNL. You have gone back home because you cannot sit with the patient. You don't have a group practice. You are working alone, and suddenly you get a call from the house surgeon who is a basic MBBS fellow or BMS, and he tells you, "Sir, usko bleeding ho rahi hai." So can you grade? Can you ask something on the phone and come to know what sort of bleeding it is?
So not sure about that.
Not sure. Great. So now this has come. This is one of the papers which was published in Urology in 2013, in which what they have done is they have taken the blood and serially diluted into normal saline up to 10 times. So from 1 to 10. So what they practice is, this scale is available, not only scale as such, but it is online also available. Anybody can download from this website, and you can, for your peace of mind, you can train your juniors or somebody who's taking care in the post-operative ward, and they can just take the color of the blood and compare and send you a snapshot, and you'll come to know what is the grade of gross hematuria grading. This is not only relevant for this bleeding, but any urology bleeding. This can, in a brain also, post-URP also, this can really help you to grade the bleeding. And this is a recent publication. This is in just 2021, urology. This is a very common thing we routinely urologists see, but the difference between us and them is they publish and we don't. If you talk to our seniors, they would have definitely told you, this is the grade of, this is a light pink color, then it goes on getting darker and it further gets darker. Everybody of us knows, but this Thomas Stout has published this, and now forever in life, we'll have to follow them and not our seniors. So this is one of the things, and this is in the Urology Journal. You can download that, and this is one of the ways. This is all the scale is available. And so if now these days they can just click a photograph, send it to you online, and you can just see the hematuria scale. The initial was gross hematuria grading, and this is the hematuria scale, which you need to know, and you should follow this. How do you know what is the bleeding? So this is the different words used: clear pink, light red, pale red, cherry, grapefruit, or bloody red, or cherry red and frank blood, like a ketchup. So this is a grading of 1 to 5. So you can always, you have to rush back, or you want to go back and see the patient again. They can just guide you when you want to go back and when you don't want to go back to see your patient. So how do you define a significant bleeding? We always say bleeding. Now, what is a definition, the literature definition of a significant bleeding for PCNL? You know that?
So not sure about the definition. Sir.
That is why we'll tell you. Any patient who is hemodynamically unstable, recurrent clot retentions in the bladder. If you have to go back to your patient, every one of us has done it. In the future, you may also come across. Don't get perturbed about it. It is mentally disturbing, but this can happen if you operate. This will happen to you also. This has happened to me also, to Dr. Harpreet also, our seniors also, but this can happen to you also. Recurrent clot retention is a significant bleeding, blood loss. So you should not wait for long. And third is when adjusted decrease in hemoglobin is more than 3.4 grams per cent. The probability that... Ji, sir. So the probability that you will require angioembolization is very high, and you should not wait, and you should perform an angioembolization in these patients. As you were discussing, the first option is angioembolization. Why is it so? Why would you prefer angioembolization? Super selective, SRAE stands for super selective angioembolization. Why do you suggest that over anything else?
So with super selective angioembolization, the least amount of renal parenchyma will become ischemic. So
before that.
So it is minimally invasive.
Exactly. Second advantage of that is
it can be done without anesthesia, local
perfect.
anesthesia.
Absolutely correct. Because the patient is very unstable hemodynamically, you don't want to give the anesthesia because how the patient will behave, you don't know. If it is an elderly patient, again, done under local anesthesia, so it will definitely give you an edge over anesthesia. You should want to avoid any sort of anesthesia in comorbid patients. So it's locally, you can do it under local. Second point is that you have to minimize the damage. So how does it affect is, these are the failures. Why does it fail? As we were discussing, these are the factors that it fails. One is when the patient is hypotension, you may not be able to demonstrate that. So you need to have a good blood pressure of the patient. Sometimes we used to give pepaverine, put into the artery and just give a pepaverine to see, sometimes delineate that. Because with the hypotension or with the small fistulas can, sleep off at the time of angiography. Once you shift them out, say nothing has happened, and evening you'll get a call, say clot retention ho gaya. So patient is definitely bleeding from somewhere. We have missed it, is our luck and patient's luck. So the second factor is multiple AVFs. So you have done multiple punctures. You don't know one AVF you may pick up, you may block, and the patient, we may have missed the other one. Fourth point is the missing of the gelatin mix. Sometimes people don't use coils because of the cost factor. So they just use blood clot or gelatin, mix it with this thing and just push it in. But that can temporarily stop, but not a permanent measure. So the choice of angioembolization proven beyond doubt is two things. What are they? What is the material you want to use?
So metallic coils I would like to.
One. Second,
permanent.
There are PVC particles available. There are small PVC particles available. You can just mix them in the saline and just push them through the coil. If the coil is not available, coil is ideal. It has been proven beyond doubt that once the coil will stop the bleeding, the probability that it will open up is very rare. So the failure to see the AV malformation initially is the lesion may be missed during the initial angiography due to the arterial spasm. Second, there may be some progressive abnormality of the vessel and it can open up later on. But if the patient does not respond to your super selective angioembolization, then the treatment of choice is nephrectomy. So don't hesitate, because mortality is unpardonable. Morbidity, yes, that's something which will haunt you, but at least you'll save the life of the patient. So this is how you define a significant bleeding in PCN. How do you reduce the risk?
So we should ensure that preoperatively the patient does not have any infection. The urine active UTI is not there. Diabetes, if it is there, should be well controlled.
Anticoagulants is always an issue. Whatever you feel safe, you follow that. You should learn the procedure very aptly. You should know your limitations. If you're not God and you will not save everyone. And so if you feel this is not a stone, I'm not experienced to do that, please take the help of your colleague. There is no harm in that. Or you refer into them, kindly do that. And with the experience, as you'll gain experience, you can do any sort of a complicated stain. Just passing out, you should not jump to do every stone that comes to your way. Miniaturization of the tract, this will help you. You use when you have to buy the instruments, because now you will soon be buying them, you should always plan, take the help of your seniors, take their guidance, ask them which scope I should buy, because you have a limited amount of money, and you should always be very sure what you are buying. Plan your procedure always a day before. It should not be like roaming practice. You have gone there and then you see an X-ray, patient is already under anesthesia. Request your colleague to WhatsApp you the plates so you can plan, and you know what your limitations are, what you expect. And if you have unplanned procedure, if you're in a hurry, and you may just, it's a matter of 20 degrees. In this CT scan, what they have shown is that there's a hardly difference of 20 degrees in making a safe PCNL versus an unsafe PCNL. So which you can, it's very easy to err on that side. So this is one of the X-rays after the bleeding complications. This is one of the other complications of PCNL. Can you see this X-ray clearly?
Yes, I can, sir.
Can you see what has happened in this X-ray, which side and what has happened?
Sir, I think there's a right-sided pneumothorax.
Absolutely, very good. So there is a right-sided pneumothorax. What is the incidence of pneumothorax in Pcnn?
Sir, around 3%.
It is 5 to 15%. For what cases it is 5 and what cases it is 15?
So I would expect a supracostal puncture, supra 11th puncture.
Exactly. It is supracostal is even supra 12th. It is not only supra 11th. So if you are supra 12th, there is incidence is around 1 to 5%. But if you go supra 11th, there is a higher probability of getting a pleural injury. So that is why reading your X-rays is very important. If you have seen an X-ray and you find that the ribs are very close to it, so you should be mentally prepared, and you can always forewarn your patient. It is better than being sorry later on in the after the procedure. So how do you manage this?
So if it is detected intraoperatively,
how do you detect
when the patient is,
how do you detect?
I can use the fluoroscopy when the patient is anesthetized. If I am able to see it,
what step of the procedure you see the fluoroscopy for lungs? When would you see?
So after the procedure, I can.
After the procedure means?
Like after I finish my Pcnn, I can look at the lung bases.
No, that will not show you because your amplats is through the pleura into the parenchyma and into the calyx. It will never show you this thing. Only when you have put a nephrostomy tube, or when somebody for you has removed the nephrostomy tube and tells you that the patient becomes breathless or is complaining of severe pain in the chest. That is the time you should expect pneumothorax, and you can see that. You cannot during the procedure. You will never come to know, and especially under anesthesia, the patients are giving a high, pressure breathing, so you will not come to know. So how do you treat that?
So if it is a small pneumothorax and the patient is stable, I can observe. But if it is a large pneumothorax, the patient is breathless, is symptomatic, the saturation is falling, I can put a tube thoracostomy. Or if it is a tension pneumothorax, I can directly aspirate it in the second intercostal space at the bedside.
Good answer. There is no such thing as small or large. Either the patient is symptomatic or the patient is not symptomatic. You should refrain from using small. Small for you may be large for me, and large for you may be small for me. So either the patient is symptomatic or asymptomatic. He's robust. He can tolerate that. You can wait for some time. Otherwise, if smallest amount of symptoms, you should not delay it. There is no harm. So this is the other X-ray. Can you see this X-ray now?
Yes, sir.
So now what do you think? What has happened here?
Sir, I think there's a left-sided hydrothorax.
Hydrothorax. Hydrothorax only or hydropneumothorax? There is never an isolated hydrothorax. Some amount of air always goes inside. And how do you know it is a hydrothorax and not a hemothorax?
It could be a hemothorax as well, sir.
Yeah. So when somebody shows an X-ray, it may be a hydrothorax or a hydropneumothorax or even a hemothorax. So because you've done a PCNL, so you never know what is there inside till the time you are going to aspirate or put in a tube. So how do you treat such patient?
So I think there is a significant collection because it is visible on an X-ray. I would like to either aspirate and send the fluid for analysis. And if the patient is minimally symptomatic, then I can observe. If the patient is symptomatic, having chest pain, oxygen saturation is dropping, I would like to put a tube.
So once you aspirate, there may be two levels of fluids. One may be a clear fluid, one may be blood. So what do you do if it is blood, and what do you do if it is clear fluid?
Sir, if it is blood, and if I'm able to aspirate the entire thing and the patient is stable and asymptomatic, I can observe, or I can put a tube thoracostomy also if the patient
is always better. You can't aspirate out of the blood, and you should preferably not take your patient third time to the OT to put a tube. See, once you have already operated one time, the patient has gone to the OT. Second time again, you take the patient to the OT to aspirate, and third time, if you take it, then they will be after your life. So you always play safe. There is no harm in putting a tube in such patients again for 48 hours, seeing what is happening. And in 48 hours, 99.9% patients get fine and they go home. If there is a persistent amount of fluid in the tube, clear fluid in the tube, then what do you expect?
So then I would expect either urinothorax. If my fluid analysis shows high creatinine and persistent the drainage, then I would expect a urinothorax. So I would like to give maximal drainage of the kidney to the patient, and I would also like to keep the nephrostomy for 48 to 72 hours.
Or till the time the fluid stops. There is no limitation about, there is no hard fast rule, because you don't want a fistula to mature and the patient to undergo something major undertaking. Good. Good. So this is what we have discussed. Treatment is early detection and chest ring placement. So this is the pulmonary complications that can happen, and we should be aware of that. And it is not that we have done an uneventful PCNL, we go back and somebody else takes the tube. You should always teach your whosoever you want to train that if there is any problem, don't hesitate to call, because it may get bad. And always remove your tubes in the morning. Always remove your tubes in the morning, never in the evening or nights. So now this is again the patient comes back to you with the pain abdomen, and this is the CT you have done. So what do you expect here? What do you see here? So patient complaining of pain, you have done a very good PCNL. Patient had gone back home and he comes within 48 hours back to you, severe pain on the left side and guarding on the left side. So what do you expect now?
Sir, the contrast is intravascating into the bowel, into the colon. I think this is a colonic injury,
which has happened and missed
intraoperatively.
And there was nothing. This is not important that. So again, coming to the point that it is not important that every time the fecal matter has to come in the nephrostomy tube for you to diagnose that. Sometimes there are smaller injuries that can happen, and the patient comes back. You don't hesitate to investigate the patient, and don't be under this impression that this can not happen to you. If it can happen to Lingman, it can Mahesh Desai sir, it can happen to us also. So anybody can have these problems. So you do a CT scan now. How do you manage these cases?
So I would like to drain the collecting system separately, and I would like to drain the colon separately. I would like the nephrostomy tube which I have played. I would pull it back so that it is inside the lumen of the colon. And then I would put a DJ stent to drain and a Foley catheter and drain both of the tubes separately.
That is to be done if there is a nephrostomy tube in place. Yes, that is the way you do it. In addition to that, what do? You can pull the drain. You should not say like that. You should say, I will pull the drain under fluoroscopic guidance. You just cannot pull it in the ward. You have to have a fluoro. You have to have gone putting the contrast and see when it is coming to the colon or not. You should be very sure, because unsure things will not make you comfortable in this case. So you always withdraw the tube under fluoro guidance. Okay? So this is not the case. The patient has gone back home and then come back to you. So now what do you do?
Sir, under ultrasound, I can, or CT guided, I would like to put a drain into the collection.
First and foremost, what is that you want to classify? Okay. So you are the only candidate. We have been grilling you. So what are the risk factors for nephrocolonic fistula? When do you expect this can happen?
So in retrorenal colons,
one
patient who have previous open surgery on the same side. Open renal surgery
on the same side too.
Rahul, you can call any other student if you like.
I thought he's the only one. We have been grilling himself.
No, they all are here.
So, okay. Then that is good. I'll just see that.
But Pradeep has held the fort very well. Yes.
He has responded very well. Good.
Yeah, he's doing very well. Both teacher and the student, both are there at the zenith of their performance.
No, sir. Has done a lot of hard work.
Ankit
Rahul has really reviewed the literature very well. He brought us a lot of many things. And absolutely with the time, still he brought the last paper also, which was lot and discussed in WhatsApp also for some time. All excellent presentation by you.
No.
You have revised so many things for all of us. Excellent presentation. And Pradeep, you have done very well.
Yes.
Anybody else want to take Rahul's question?
Ankit, can you just tell me, if this patient comes back to you, what is the first thing which you want to diagnose in a nephrocolonic fistula, which is of importance for management of the patient?
So if there is intra-abdominal sepsis, patient is presenting with the pain. So
what do you want to differentiate? What is this fistula? This has happened. Injury has happened. Injury can happen to anybody. no points in that. What is this? What do you want to differentiate? Because the managements are absolutely different.
So whether it can be conservatively treated or he needs a laparotomy.
What injury can be treated conservatively and which injury would you like to treat it by exploration?
So if the patient is developing abdominal distension, signs of peritonitis, tachycardia, fever.
That means that your nephroclonic exactly. Yes, so what you have to, that is the answer I'm looking for. So first thing, if the patient is diagnosed in house, then things are different. As Pradeep said excellently, that you withdraw that under fluoroscopic guidance, put up a DJ stent, give maximum drainage. In addition to that, you put the patient on TPN for a few days and do a rectal examination, give him a suppository, keep the distal end open. That is basics. But if the patient has gone back home, you don't have a tube inside and the patient comes back to you, the first thing is that you have to differentiate whether it is an intraperitoneal or an extraperitoneal injury, because that is a difference between life and death for the patient. So what are the indications that show you that it is an intraperitoneal injury? Like you were saying?
So they will be guarding rigidity.
Yes.
And pain abdomen, sir. So yes, feature of sepsis will be there.
Exactly. So in that case, you cannot hesitate and you have to go back and, you have to do explore the patient and look where the things are, and then you have to do accordingly. So like what he was saying, this is a slide we should always remember, because now a lot of people are doing supine and prone PCNLs. The supine PCNL has some limitations, and this is one of that if you are not behind the posterior axillary line, then the probability of having a bowel injury is higher in a supine PCNL. It has been documented. So the risk factors are elderly patients, hypermobile kidneys, kyphoscoliosis, horseshoe kidneys, decreased retroperitoneal space as renal colon, anterior calyx if you're doing it, and if you're lateral to the posterior axillary line, then there's a probability, and even in the prone position, if you go very laterally, there is a probability that you may injure the colon. So again, time of detection and intra and extraperitoneal injury is most important. So I think the evidence of sepsis, fever, leukocytosis, as you said, is the bad omen, and you have to go and explore the patient. So that is all, I think. Thank you, Harpreet. Thank you, Ranjan Boss, for having me here. It was a great privilege. Now, if Harpreet, you are here, would you like to take that?
Yeah, Rahul, I would say it's one of the brilliant presentation.
Yes.
You have really done justice to complication. The way you framed the questions and the way you decided everything, it was really very. We all learned from your presentation. We all got wiser from your presentation. And Pradeep, you did very well. I'm sure this will help everybody. And as you will hand over this presentation to Dr. Ranjan Day, it will be in our archives. And I think if anybody has any questions, they can ask directly to Rahul, and if not to Rahul, to students. And then otherwise, we will proceed with the MCQ so that we can finish on time. We still have exactly the time we wanted. We have 20 minutes with us. So Rahul,
I think you should go ahead with the MCQ questions so that we can finish it in time.
Yeah, Rahul will take over that.
I'll do that.
Thank you.
Okay, now all candidates should be on, and they have no excuse not to be there, because we may ask anybody. That will show whether they were attending also or not. So as Harpreet yesterday said, because that is the final test, because I am really thankful to all the consultants who have given a time on a Sunday and be here. Almost 6 hours of endourology we have been discussing, and they should do justice. The candidates should also do justice to what consultants have prepared. So now, Pradeep, you take the first question. Which of the following condition is associated with increased risk of nephrolithiasis?
Some metabolic syndrome.
Metabolic syndrome. Good, great. So the metabolic syndrome is characterized by obesity, hypertension, dyslipidemia, insulin resistance, and associated with increased risk of stone formation. See, this is very important, because not only when you remove the stone, a lot of patients will tell you, doctor, we have spent money, we have come back. What is the incidence of hamare ko dobara to nahi ho jayega? But then you have to be very clear with them that since you are suffering from 1, 2, 3, 4, you have a higher probability of getting the stone disease. Okay. So now this question can be taken by Divankar. Loji bole. The best predictor of urosepsis is
stone culture.
Stone culture.
Stone culture, sir.
Okay. So that is the best predictor. It is very difficult to get stone culture. All of us are usually, we don't do it. But yes, you should do the stone culture if it is possible and feasible. That will give you a good predictor of what the patient is suffering from. That is why in literature they say that the urine you collect may or may not be predictor for the sepsis in the patients, as 30% of chances are that the culture may differ in the when you have done a definitive thing for them. Who would like to take this question? Do we have Ankit? Aap le lo ye wala?
Yes, sir.
We'll give it to Ankit this time. What is the risk of mortality of untreated this thing in a staghorn stone?
So 10 to 20%.
10 to 30%. Good. अच्छे से सुना है आप लोगों ने यार. Good, great. I'm very happy that you have been participating. So this is the thing that, so we should be aware of these. See, these percentages one should try to remember, because this makes your life very easy. If somebody confronts you on a wrong foot, sometimes you may get an infection and some may comment, but you should be showing that the literature is there and this is nothing new which has happened to you. Siddharth, you can take this question. What is the preferred treatment approach for a symptomatic 1.5 centimeter stone in the lower calyx or in the diverticulum?
Sir, D, Pcnn with fulguration of the diverticulum.
So the reason for that is?
Fulguration prevents recurrence of stones in the diverticulum.
So the stone clearance is the most important component. The patient has come to you for stone clearance. Any patient who comes to you will be coming for stone clearance. So the first criteria, whenever you choose in your life, what procedure you want to use is what is the minimal morbid way you can get 100%, almost 100% stone clearance. Because in India, they want 100% clearance. So this is the Ehsan.
Yes, sir.
Are you there? Which is the preferred treatment option for the patient with symptomatic 1.5 centimeter renal calculus and a coagulopathy?
So answer is already, I have.
It's already there. Sorry.
Yes, sir.
This answer is already there. Okay, but still, you should always remember that it is quite safe in coagulopathy. Doing a RIRS is quite a safe option, provided you are not pushing the things. If you push the things and even a small amount of bleeding happens in RIRS, don't spend or waste your time in the kidney. Stage the procedure, go back again. Don't try to finish it up. Like in PCNL, even if there is a small amount of bleeding, you can, just carry on for some time with the pressure and things like that to get the vision clear and break the stone and take it out. But in RIRS, don't try to do that. If there is any amount of bleeding for any reason, just stage the procedure, because believe you me, you will not be able to clear the stones otherwise. ये वाला question बोले आप. The risk of ureteral perforation status with the following intracorporeal lithotripsy technique. Which is the one?
The electrohydraulic.
Electrohydraulic. Anybody else, Siddharth?
Holmium laser.
EHL is a major disadvantage is that it is damage the ureteral mucosa and associated with ureteral perforation. It causes more damage than any other thing. Holmium laser, yes, it can cause if you're not using it in an adequate way. So what is the preferred initial setting for holmium lithotripsy for ureteral stones?
The A 0.6 and 6 hertz.
Yes, good. Why?
So the minimum setting, it is the minimum setting that can break the stones. So
no, that is not the reason why. Because higher the energy, one is the retropulsion, second is the damage to the ureteral mucosa, the temperature rises very heavy. So in those cases, you don't want a very high temperature in the ureter. It is true for TFL as well as this thing. Okay. Yes. So which intracorporeal lithotripsy technique is efficiently fragment and evacuate the renal calculus?
Combination ultrasonic ballistic lithotripsy.
Great. This was a straightforward question. Not all of us can afford, but wherever possible, the lithoclast master is the best way to remove the stones in a complete manner. The primary insult to the kidney exposed, where is the basic things what happen?
The glomerulus.
Blood vessels.
Yeah, it is a vessel, in particular vessels which you are puncturing and dilating the tract that can cause more damage than help. You should always, if the initial puncture shows blood, you should not dilate that tract preferably. Okay. The most common secondary infection after percutaneous stone removal is?
Enterococcus.
I don't think so.
Enterococcus.
Secondary
Staph epidermidis.
Staphylococcus epidermidis.
Epidermidis.
Enterococcus.
That is no. The D is the right answer. So more common is Staphylococcus. This is what we have also seen clinically. The risk factor for clonic injury during PCNL, except
upper pole puncture.
Upper pole.
Correct. Absolutely correct. So to minimize the risk of lung and pleural injury during supracostal puncture, what do you want to do?
The puncture should be performed during full expiration.
Yeah, that is one of the ways of avoiding it. But the only issue is that then you cannot go to a lot of calyces and in that case. But that is one of the ways of avoiding the injury. Most common serious error in excess is
Over advancement of dilated sheath.
And how do you avoid that?
For
a beginner?
So we have to be always ureteric catheter se pehle rehna.
That is why I have seen people saying, why use ureteric catheter? Ureteric catheter is mandatory. That gives you an idea where you're in the system. Or if your puncture is clean, you can always put some contrast there and you will know the medial dilatation of this thing. So you can get away in a PCNL if you have underdilated it, but you have overdilated it, it's a trouble for you. And if there is a perforation, don't hesitate to put a tube and come out. Don't carry out because of what syndrome can happen? A TUR syndrome or a compartment syndrome can happen if you don't take the things seriously. So if there is a perforation, frank pelvic perforation, you see the perforation and fluid going out, you just stop the PCNL, put a tube, come out, go back after 72 hours. It will be very easy for you. Middle or upper calyx pole excess of PCNL and horseshoe kidney is preferred for all the following reasons except
higher incidence of retrorenal colon.
No, he's right. There is a higher incidence of retrocurrent colon, so you don't want to go in a middle or calyx. You want to go upper pole. Lower pole should not be done. What is the risk of AVF malformation in a PCNL? 1 in?
1 in 500?
No, not 1 in 500. It is 1 in 200. So it is 0.5% of the patient require emergency angioembolization. So it's rare. Fortunately, it is rare. Usually these bleedings subside by their own. You don't have to do much for them. In case of uncontrolled bleeding persists after nephrostomy tube of PCNL, what would be the preferred approach? We just discussed
insertion of case tamponade balloon.
Case tamponade balloon or immediate? Immediate. What I follow in my clinical practice is if I'm suspecting a bleeding at the time of taking out this thing, I keep a Foley's catheter ready with me. I may not have a K tamponade balloon. You just take a simple Foley's of a smaller size than the nephrostomy you have put. And if the bleeding starts, just put a Foley's, inflate the balloon and wait. It will give you some time for angioembolization. Simple Foley's does the trick. The use of double jet stent to reduce the Stein stent ESW has been demonstrated beneficial for what side of stones? What size of stones you say we'll put a stent and then do ESWL, if at all you have to do?
So greater than 15 millimeters.
15 millimeters, not 20 mm. Okay, 2 centimeter stones and beyond. Then you have to look for Stein stress. Ureteral perforation is noted after fragmentation of the calculus. On inspection, the perforation of the stone fragment is not there and the stone has gone into the retroperitoneum. What would you do?
Terminate the procedure
and place a uterus.
Absolutely. Someday in life you will encounter that. So don't hesitate, put up a stent, come out and let the patient live for a next day. What is the proper management of stone trapped in a basket, an avulsed ureter, all in continuity, no safety wire place? What do you do?
Placement of percutaneous nephrostomy drain.
Exactly. That is the way you have to do. You have to accept that something bad has happened, put a nephrostomy tube. And why should you do that is, one, you are not prepared for any major surgery. Two, second, your brain stops working with such sort of a horrific complication. Three, you need help that may not be available. And fourth, you have to plan the procedure. You have to talk to the attendants and take up for a body or whatever you want to do. So it is always better to place a PCN and then, accept it and move on in life. Thank you very much. Thank you, Ranjan boss, for having me. It was really honor and thank you. Good job. All boys are doing good job. All third years have done good.
Yeah, the purpose of this class is to encourage our students and to prepare them for the examination. Today, Harpreet and his entire team, Nitesh, Sandeep, Rahul, everybody and all the students have performed beyond their sphere. I really thank all of you to make it a big success. And at the same time, I also thank Dr. Harpreet Singh for organizing such a beautiful session for the students of his zone. And I think many other students from outside also have joined. But the most important thing, we have the presence of Dr. Shivaji Basu, who has immense experience in the stone surgery in this zone. So I will request him to say few words as a words of wisdom for the students and also for us.
Thank you, Ranjan. I'm impressed. I'm impressed with the students. I'm impressed with the teachers. So that was a very, very fruitful discussion. It covered almost all the chapters. If you take it from yesterday, there was, and it is actually covered the whole of the chapters. And Rahul very nicely did the justice in the last PCNL part.
Thank you, sir.
And I'm glad Pradeep stood the whole thing, the grilling very well, very well.
Thank you, sir.
Well done. Thanks, Ranjan. Thank you.
Thank you, Pulanda. We want to say something?
Nothing to add. Have a very good Sunday, all of you. I think it was an excellent meeting.
Thank you. Thank you very much. Once again, Harpreet, Rahul, Sandeep, everybody, Nitin, we'll meet once again next weekend. Next weekend, we have a very important topic that will be on renal as well. And Dr. K.K. Sarkar, our president, will be the moderator. So we are hoping for a much bigger expectations for the next weekend. And from now, I welcome all of you to attend in numbers. Thank you. Thank you very much.
Thank you very much.
Thank you, Harpreet. Thank you.
Bye, Harpreet.
Bye, sir. Bye, sir. Thank you.
Thank you, everyone.
Bye, bye.